मॅडम आपण लाईव्ह आहोत, तुम्ही सुरुवात करू शकता. थँक्यू.
Good afternoon, everyone. I am Dr. Yugali Kore, Junior Resident at Vedanta Institute of Medical Sciences, Dahanu, and I'm doing MD Pediatrics currently. So I welcome you all on behalf of Palghar Academy of Pediatrics for today's CME. We have this online session at a very short notice, but we will still make it successful. So let me introduce to our very first speaker. आपल्या सगळ्यांचेच लाडके, आपण ज्यांना खूप चांगल्या प्रकारे ओळखतो, सिनियर पीडियाट्रिशियन डॉक्टर जोशी सर. त्यांचं हे जे सेशन आहे ऑन आर्ट ऑफ प्रॅक्टिसिंग हॅपीली, ते आज आपण सुरू करूयात. सर, मी तुम्हाला रिक्वेस्ट करेल की तुम्ही तुमची स्क्रीन शेअर करा आणि तुमच्या टॉकला सुरुवात करा.
हो सर, फुल स्क्रीन दिसतंय तुमचं
हो
प्रॉपर.
हो बघतो का
हो.
काय होईल नमस्कार. एक म्हणजे मी मराठीत बोलणार आहे, कारण आपण इंग्रजीत नीट शिकलो नाही हे एवढं तरी आपल्याला कळलं असेल असं मी समजतो. आपण जेव्हा 100 रुपये घेतो ना, तर आपण बोललेलं 100 रुपयाचं त्यांना जर कळलं पाहिजे. त्यांना जर निम्मं कळलं, त्यांनी निम्मेच पैसे दिले तर आपली प्रॅक्टिस अर्धी होऊन जाईल. आणि त्यांनी 4 आणे कळलं तर 25% दिले तर पैसे 25%, म्हणजे जो पैसे देतो ना त्याला फुल रिटर्न मिळालं पाहिजे. तर त्याला कळेल अशा भाषेत बोलता आलं पाहिजे. पोपट असतो ना, तो काही दिवसात घराची भाषा शिकतो. मग आपण त्यापेक्षा हुशार आहे की नाही? तर आपल्याला 12 भाषा आल्या पाहिजेत, आपल्या कामाच्या तरी आल्या पाहिजेत. तो पेशंट जी भाषा बोलतो ना, ते आपण 5 वेळा तोंडात बोललं, भिंतीवर लिहून ठेवलं, हातावर लिहिलं, कागदावर लिहिलं, तर ती भाषा येऊन जाते. खूप सोपं आहे. तर हे करून बघा, बहुभाषी व्हा, तर तुमचं काम खूप वाढेल. पहिला मुद्दा. दुसरा मुद्दा, क्राय फ्री हॉस्पिटल पाहिजे. जो देतो तो देव ना. तर आपला देव कोणा बाळ आहे, त्याला रडवतं कसं तुम्ही? त्याला आईपासून जर बाजूला केल्याने तो रडत असेल, तर त्याला आईच्या मांडीवर का तपासत नाहीत? घसा बघायचा असेल ना, मी काहीतरी, तुम्ही सगळे खूप शिकलेले आहे बरं का, तर पहिले आधी कान धरतो. तुम्हाला शिकवण्याची माझी लायकी पण नाही. पण घसा जर बघायचा असेल, तर तुम्ही जर सॉफ्ट कॉटनचा बॉल पॅलेटला लावला ना, तर गॅग रिफ्लेक्स होतो आणि नकळत बाळ घसा दाखवतो. तो जर बसलेला असेल ना, तर गॅग केला की खालचा जबडा खाली पडतो आणि घसा छान दिसतो. बरं, त्याला सर्दी आहे, नाक गळते आहे, त्याला ताप आहे, हा, तर घसा बघायची गरजच नाही ना. बलात्कार म्हणजे बाळाचा घसा बघणे. तुम्ही कशासाठी करतात? तुमच्या नाकात घाला बरं तोंड, 1 चमचा रोज तोंडामध्ये. तर क्राय फ्री कसं करता येईल? कशा रडतो बाळ? तो आल्यावर तुम्ही तापमान मोजतात. आता तो त्याला ताप आहे की नाही आहे हे इम्पॉर्टंट आहे. ताप थोडासा आहे, खूप आहे, अति आहे, हे इम्पॉर्टंट आहे. एवढ्याने ट्रीटमेंट ठरते. ते तर हात लावून पण कळतं. मग तो 101.5 आहे का 101.6 आहे, ते आम्ही केसाचे 12 भाग करतो ना. 2 प्रकारचं वैद्यक आहे मेडिसिन, कामाचं आणि कमी कामाचं. ताप आहे, थोडा ताप आहे, मध्यम ताप आहे, खूप ताप आहे, हे कामाचा वैद्यक आहे. आणि 103.5 आहे आणि 103.6 आहे, हे कमी कामाचा वैद्यक आहे. पण तो थर्मोमीटर लावल्यावर जर तो बाळ रडत असेल, तर तुम्ही इन्फ्रारेडने लांबून ताप मोजायला पाहिजे. आम्ही काय केलंय, आपली ओपीडी हे खेळघर पाहिजे. मी मुलांना यावं वाटलं पाहिजे, त्यांना मज्जा आली पाहिजे. आमच्याकडे खूप मुलं गेल्यानंतर स्टेशनहून परत येतात की आज आम्ही कुरमुरे नाही खाल्ले, आज आम्ही खाऊ नाही खाल्लं, आमचं खेळायचं राहिलं. तर आपलं आनंदी घर करता येईल का आपल्याला, असं बघा. तर देवघर झालं पाहिजे. आपलं बाळ देव आहे ना, हे बाळाचं देवघर आहे. तर बाळ हसला पाहिजे, त्या बाळाच्या आईला आपलं माहेर वाटलं पाहिजे. आम्ही काय केलं, जुने स्टेथोस्कोप्स, जुने थर्मामीटर्स, जुने पल्सॉक्स, जे जे मुलाला आपण लावतो ते त्याला अननोनची भीती वाटते. सो त्यांना जर खेळायला दिले तर त्याच्या ओळखीचे होतात ना. मग त्याला माहिती आहे काय, स्टेथोस्कोप काय दोरी आहे, साप नाही आहे. तर तो स्टेथोस्कोप लावला रडत नाही. थर्मोमीटर पाहतो, हातोच खेळतो, त्याला भीती नाही. पल्सॉक्सशी खेळतो, मग त्याची भीती निघून जाते. सो चांगले सुद्धा स्टेथोस्कोप ठेवले ना, तर तो स्टेथोस्कोपचा सगळ्यात चांगला उपयोग आहे. तुम्ही गेल्या 10 पेशंट ऑस्कल्टेट केले, किती वेळा तुमच्या कामी आला मला सांगा. तुम्ही तुमचे हुशार. स्टेथोस्कोप गळ्यामध्ये जेवढा उपयोग आहे ना, त्यापेक्षा जास्त तो मुलं याशी खेळले ना तर होईल. तर आनंदी कसं होईल बघा. ते केव्हा केव्हा रडतात, ताप मोजताना रडतात, स्टेथोस्कोप लावलं की रडतात, ते पल्सॉक्स लावलं की रडतात, थर्मोमीटर लावलं की. त्यांना खेळायला द्या. त्यांची भीती गेली की ते छान होऊन जातं. मग त्यांना आमच्याकडे कुरमुरे भरून ठेवलेले असतात. आम्ही त्यांना शिरा देतो. ऍक्च्युली आमच्याकडे बाळकृष्ण आमचा देव आहे, आमच्या दवाखान्याचा. तर बाळकृष्णाची पूजा म्हणून त्याला 2दा आमच्याकडे शिरा होतो, ताजा छान शिरा होतो. आणि तो सगळे खातात. याचे 2 फायदे आहे बघा. सगळे आजारी मुलं पण शिरा खातात बरं का. त्यांचे आई वडील पण खातात. आणि त्याने रक्तातली साखर वाढली ना, की मेंदूमधला आनंदी रसायन डोपामिन वाढते आणि ते आनंदी होतात. आपण सगळे होतो, म्हणून तर आपण साखर खातो ना. किंवा अन्न खाल्लं की साखर बनते, त्याने मजा येते. तर ते त्यांचा उपाशी पोटी सुई जास्त दुखते, शिरा खाल्ल्यावर कमी दुखते. शिरा खाल्ल्यावर त्रास कमी होतो आणि आपण आनंदी राहतो. तर मुलं आनंदी राहतात. त्यांना काहीतरी खाऊ द्या, शिरा द्या, कुरमुरे द्या, काय द्या, तर ते आनंदाने खेळतील. मग मी एकदा काय केलं, की माझ्या मनात खूप दिवसाचं होतं की फुगे आणायचे म्हणून. कारण बोळींला फुगा फॅक्टरी होती, विरार ईस्टला कामतांची फुगा फॅक्टरी होती 85ला मी जेव्हा आलो तेव्हा. ती आता डहाणूला गेली. पण फुगे काही मिळे नाही 40 वर्ष बरं. म्हणजे इच्छा आणि अंतरामध्ये, कृतीमध्ये 40 वर्ष अंतर पडलं. पण मी एक दिवशी हट्ट करून नेटवरून पत्ते काढून माणूस पाठवून डहाणूच्या फुगा फॅक्टरीमधनं 5,000 फुगे आणले. खूप फुगे आणले ऍक्च्युली, पिशव्या पिशव्या, आणि ठेवून दिले. आणि मग आम्ही गेलो इंग्लंडला. माझी नात इंग्लंडला आहे. ती मुलीला विचारलं, अगं फुगे आणू का? ती म्हणे, बाबा काही नको, माझ्याकडे खूप आहे. तू काय आणू नको, तू ये बस, तू काय फुगे बिगे काय आणू नको. मी आपलं काय ऐकलं नाही, एक फुग्याची पिशवी बॅगमध्ये टाकून दिली. आणि तिथे गेल्यावरती काही फुगे फुगवून दिले. ती एवढी आनंदाने खेळली माझी नात. तर मला असं लक्षात आलं की मुलांसाठी, छोट्या बाळांसाठी फुगा सगळ्यात आनंदाचा खेळ आहे. का बरं? त्याची इजा होत नाही, जखम होत नाही, ट्रॉमॅटिक, लाईट वेट, तो उडतो, त्याच्या मागे मुलं धावतात, पकडतात, फाडतात, फुटतात, जे काय करतात ते. बघा, अॅनाफॅलॅक्सिसची रिस्क आहे तरी अँटीबायोटिक देतो, तशी फुग्याला रिस्क आहे. जयश्रीताई, तुम्ही कॅमेरा, तुम्ही घरी तुम्ही चहा पित आहेत का ना? सगळ्यांना विनंती, कॅमेरे ऑन करा. मला असं वाटतं की मी भूतांशी बोलून राहिलो.
सर, तुमचं प्रेझेंटेशन बंद केलंय का तुम्ही?
हो, मी बंद केलंय. मला नको. प्रेझेंटेशन इज अ न्यूसन्स गत आहे.
हो सर, काही हरकत नाही. ओके.
प्रेझेंटेशन इज अ न्यूसन्स. गुड. चला राणे सर, थँक्यू. की ते भूताशी बोलल्यासारखं वाटतं. आणि मला अजून तशी मला सवय आहे, पण एवढी सवय नाही. सलग भूताशी सलग नाही बोलतायत मला. जिवंत भूत पाहिलं. थँक्यू युगालीताई. सगळ्यांना 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 प्लीज विनंती, तुम्ही तुमचे कॅमेरा चालू ठेवा. तर ती एवढी खेळली ना, की तिने मला मला माझ्या नातीने खूप शिकवलं. तिने मला शिकवलं की फुगा ही सगळ्यात छान गोष्ट आहे. मग आम्ही ते आणलेले सगळे फुगे उपटी ठेवून दिले. प्रत्येक मुलाला मी एक फुगा देतो. आई बाबांना म्हणतो फुगवा. आई बाबा बिझी होऊन जातात, पोरं खेळतात, घरी घेऊन जातात, काय वाटेल ते करतात, रडण्याशिवाय सगळं काय करतात. मग अजून तुम्हाला काय पाहिजे? ते हवा असं करून घशात गेला तर अडकेल की नाही. तर 1,00,000 फुगे वाटल्यावर आमच्याकडे काही ऍक्सिडेंट नाही. म्हणजे हे थिरोटिशियनना जाऊ द्या, त्यांचं ऐकू नका. ते काय करतात की अॅनाफॅलॅक्सिस होतं, अरे एवढे अँटीबायोटिक वापरतात, त्याला अॅनाफॅलॅक्सिस नाही सांगत. असो, तर फुग्याची रिस्क आहे की ते श्वासनळी थांबवू शकतं, तेवढं. बाकी काही रिस्क नाही आहे. मुलं खूप खेळतात, छान. मग फुग्यातनं मी नवीनच शिकलो एक मुलगा आला 10वीतला, मोठे मोठे गाल, मोठी मोठी मुलगा, मोठी ब्रेस्ट, गोल गोल मोठं पोट आणि मोठं स्क्रोटम आणि नॅनो पेनिस आणि टेस्टिस, नो टेस्टिस, ओनली फॅट, सगळीकडे फॅट फॅट. आणि त्याला मुलं रडवायची की हा मुलगी आहे. 10वीतला मुलगा होता. तर त्याचे बाबा काळजी नाही आली की याला कसं, बाकी सगळ्यांना दाढी आली, मिशी आली, हाला नाही आली, हा असा गोल आहे, हाला काही गडबड आहे का, एंडोक्राईन प्रॉब्लेम आहे का. मी म्हटलं बघा, अंडकोश जे असतात ना ते 4 मिलीमीटर लहान मुलांचे असतात. 4च्या वर वाढले, 10-15 झाले की तुमचा मुलगा मोठा होऊन राहिला, तो छान होणार. कसं बघायचं, मोजायचे कसे अंडकोश. माझ्याकडे काय ऑर्किडोमीटर नव्हतं. मी काय केलं, एक फुगा घेतला छोटासा, त्याला सिरिंज लावले, 25 ml पाणी घेतलं सिरिंजमध्ये आणि तो फुगा फुगवला. केवढा फुगवला, त्या टेस्टिसच्या साईजचा होईपर्यंत. आणि मी त्यांना सांगितलं की बघा, 10 ml जरी व्हॉल्यूम असेल ना तरी तुमचा मुलगा छान आहे. याची 12.5 ml आहे, तो तुमचा मुलगा छान आहे. आता तो मुलगा, त्याचं लग्न आहे परवा. रिअली परवा लग्न आहे त्या मुलाचं, तो अमेरिकेत आहे आता. सो मी फुग्याचं ऑर्किडोमीटर तयार केलं आणि गोष्ट सांगतो त्याची. हे केलं आम्ही संध्याकाळी रात्री 10 वाजता केलं आम्ही. म्हणजे तो लास्ट पेशंट होता, घरचा ओळखीचा होता. आणि माझ्याकडे सायनमधनं लेक्चर होऊन असलेला आणि रिझाईन करून प्रॅक्टिस चालू करायची म्हणून सरावासाठी आलेला एक हुशार सोबती होता. आम्ही दोघांना लिहून काढलं रात्री 12:30पर्यंत बलून ऑर्किडोमीटर, आणि सगळ्यांना व्हॉट्सअपने तर पाठवूनच दिलं. तर इंडियन जर्नल ऑफ पिडियाट्रिक्स, IJP आहे ना, इंडियन पिडियाट्रिक्स ना, इंडियन जर्नल ऑफ पिडियाट्रिक्स, तर त्याचे IC वर्मा सर, त्यांचा मला सकाळी मेसेज आला, अरे पाठव IJP ला पब्लिश करायला. मग मी लिहायला घेतलं वगैरे. आणि मग मी अर्चना पटेल, मोठी सायंटिस्ट आहे, पिडियाट्रिशियन, खूप पेपर्स वगैरे, HOD IGMC. ती म्हणाले, हेमंत पहिले तू एक ऑर्किडोमीटर आण, मग त्यांची कम्पेअर कर की ऑर्किडोमीटरने किती येते, फुग्याने किती येते, आणि मग पब्लिश कर. हे काय असं काम असते का. मी गाढव का बरं, दुसऱ्याचं ऐकलं म्हणजे गाढव. मग त्यात ते झालंच नाही. नंतर मी ऑर्किडोमीटर कुठेच नाही मिळालं. मग माझ्या इंग्लंडच्या पोरीला सांगितलं, तिने ते नेटवरून मागवलं, ते इटालियन कंपनीने दिलं आणि ते होतं चायनामधलं. ते आहे काय, नुसते लाकडाच्या गोळ्या आहे. आपण फणसाच्या बिया जर डिफरंट व्हॉल्यूमच्या घरी ठेवल्या ना, तर ऑर्किडोमीटर तयार झाला. पण अजून सोपं म्हणजे बलून ऑर्किडोमीटर इज द बेस्ट. मग काय झालं, अजून मला दम्याचा त्रास आहे. तर तो सिपलाचा माणूस एव्हरी वेडनेसडे लंग फंक्शन करायला येते. मी माझं लंग फंक्शन केलं, तर म्हणजे लंग व्हॉल्यूम 3 लिटर आला. खूप हवा घ्यायची, सगळी हवा सोडायची, लांब हवा घ्यायची आणि एकदा फ्लो करायचं. मॅक्झिमम हवा किती फ्लो करत, 3 लिटर आली. मग मी घरी आलो, समोर फुगे पडले होते, एक फुगा घेतला, जोरात ब्लो केला. किती मोठा झाला बरं. तर त्याचा मला फॉर्म्युला माहिती होता. फुग्याचा जर तुम्ही सर्कम्फरन्स काढला स्फिअरचा म्हणजे, तर तुम्हाला व्हॉल्यूम कळतो. तर तो 3च लिटर आला. तर मला कळलं की फुगा इज द बेस्ट स्पॅरोमीटर. तुमच्या मुलाला एक युगाली तू रिसर्च कर केव्हा तरी. मला हे कळलं की मुलाला समजा दमा आहे, त्याला आपण सांगतो अरे तुला श्वास कमी मिळतो, त्याला कसं कळेल, दाखवता आला पाहिजे. हा सूर्य आहे जयद्रथ, त्याला एक फुगे, सगळ्यांना चांगले चांगले फुगे देऊन टाकायचे. गुड बलून, बिग बलून. त्याला सांगायचं फ्लो कर, त्याला दिसेल एवढं एवढं करतो. त्याला सांगायचं त्रास झाला की परत कर. तो जर कमी फुगला तर तुला ऑब्विस आहे ना. समजा माझी लंग फंक्शन 50% झालं, तर लंग म्हणून 50% लॉस ऑफ व्हॉल्यूम करतो ना फुग्यामध्ये. मुलं जाम हुशार असतात, त्यांना 10% पण कळेल. तर बलून तुम्ही वापरा, बलून फ्लोईंग लंग फंक्शन इम्प्रूव्ह होतं आणि बलून बॅरोमीटर तयार होतं. सो हे झालं 2. पण मला ऍक्च्युली दुसरंच काय काय सांगायचं. माझ्या नातीने मला अजून एक रिसर्च सांगितला, ते मी तुम्हाला आता सांगणार आहे. तर ते असं आहे की अर्चनाचं भाषण होतं. मी दिसतोय ना तुम्हाला. अर्चनाचं भाषण होतं झूमवर, कॉम्प्लिमेंटरी फीड्सवर. आता माझी नात 2 वर्षाची आहे. तर मी तिला, राधिका मुलीचं नाव आहे, नातीचं नाव रेवा आहे. तुम्ही राधिकाला विचारलं, बाई तू रेवाला कसं मोठं केलं. तर ती मला म्हणे मी सातूचं पीठ दिलं आणि ती छान मोठी झाली. तर मला लक्षात आलं की मी 71 वर्षाचा आहे आता. सो गेली 40 वर्ष मी फक्त चाइल्ड न्यूट्रिशनवर बोलतो, काम करतो, काय केवढी पुस्तकं गेली, 12 भाषेत करतो, व्हिडिओज सगळं करतो, पण माझ्या सातूच्या पिठाकडे लक्षच नाही. मग मी सातूच्या पिठावर रिसर्च चालू केला. तो मला तुम्हाला आता सांगायचा. सर्वाधिक गोष्ट जी इंग्लंडला आमच्या घरातनं गेली 2 वर्ष, ती फक्त सातूचं पीठ होतं. आणि आमचं जगातले सगळे मुलांचे अन्न हे सातूच्या, त्याची ग्रँडमदर आजी सातूचं पीठ आहे, त्यातूनच ते जन्माला आलेले आहेत. कसे ते सांगतो. आपण ज्याला सातूचं पीठ म्हणतो ना, ते कसं करतात की गहू आणि हरभरे यांना भाजून दळून एकत्र करतात, त्याला सातूचं पीठ म्हणतात. त्यात पाणी, दूध किंवा ताक टाकून त्याला कालवतात आणि भरवतात. चवीला मीठ टाकतात, साखर टाकतात, कोणी जायफळ टाकतात, कोणी वेलची टाकतात, आपल्या आपल्या मर्जीने ज्या ज्या घराचं जे. पण अल्टिमेटली ते काय घालतात, खाऊ घालतात. तर गहू आणि हरभरा, चणा. पण मला माझ्या मुलीकडनं मी शिकल्यावरती मी जो रिसर्च केला ना, त्याने मी उडालोच. तो मला तुमच्याशी शेअर करायचा आहे. सर्च म्हणजे शोधणे, रिसर्च म्हणजे पुन्हा शोधणे. तर मी पुन्हा रिसर्च केला सातूचा आणि मला काय मिळालं बघा. तर सातू इज द ओनली कम्प्लीट फूड ऑन द अर्थ. जगातलं एकच संपूर्ण अन्न आहे, ते म्हणजे सातू. आणि सगळ्यात पहिले आहे आईचं दूध. आणि मग आईचं दूध कमी पडल्यावर तुम्ही सातू जर दिलं ना, तर मुलांचे सगळे प्रॉब्लेम दूर होतील. मुलांचे काय प्रॉब्लेम आहेत? 10 पैकी 9 मुलं दुसऱ्या वाढदिवसाला मालनरिस्ट आहेत, कारण अन्न कमी पडतं. सातू दिलं की जाईल. हे मुलाला या मुलांना आणि सर्व वयाला कॉन्स्टिपेशनचाच आजार सगळ्यात मोठा आहे, कारण फायबर कमी पडतं. सातूच्या पिठामध्ये, डाळीमध्ये सगळ्यात जास्त फायबर आहे, मग त्यांनी कॉन्स्टिपेशन टळते. किती छान आहे. पण काय झालं की 1000 वर्षाच्या गुलामगिरीत आमच्या लायब्ररीज जळाल्या, आम्ही पुन्हा खराब झालो. मला अभ्यास केल्यावर असं काही शिकलो मी की सातूचं पीठ म्हणजे 7 वस्तूपासून बनते, म्हणून सातूचं पीठ. मग 7 काय आहेत? तर पहिलं आहे जवस. महाराष्ट्रामध्ये, म्हणजे कोकणात नाही, कोकणात भात खायचे, मला माहित नाही कोकणात, मी कोकणात, मला अभ्यास नाही. पण महाराष्ट्रामध्ये, विदर्भामध्ये, मराठवाड्यामध्ये तेल जवसाचं होतं आणि भाकरी ज्वारीची होती. गहू नव्हता, तांदूळ नव्हता. जवसामध्ये ओमेगा 3 फॅटी ऍसिड आहे, DHA, ज्याने मेंदू बनतं. किती लागतं आपल्याला? तर 20 ग्राम जवस रोज खाल्लं पाहिजे, किंवा त्याच्यात 10 ग्राम तेल, त्यात 50%, 10 ग्राम तेल खाल्लं पाहिजे. आणि बाळंतिणीने 30 ग्राम जवस खाल्लं पाहिजे, कारण बाळाचा मेंदू पोटात सगळ्यात जास्त वाढतो ना. तर आईला जर तुम्ही सातूचं पीठ दिलं ना, तर तिचा बाळाचा डोक्याचा घेर वाढेल, तो मुलगा प्राईम मिनिस्टर होईल, नोबेल प्राइज मिळेल. अजून काय शोध लागला, तर 7 वस्तू काय आहेत? तर 1 तेलबी आहे, 3 धान्य आहेत आणि 3 डाळी आहेत. 3 धान्य कुठले? ज्याला अंकुर येतो, म्हणजे गहू आहे. तांदूळ नाही, तांदूळाला अंकुर येत नाही, तांदूळ मोडलेला असतो. गहू, ज्वारी, बाजरी, नाचणी, रागी, जे त्याला अंकुर येईल ते. डाळी कोणत्या? चणा डाळ, म्हणजे हरभरा, मूग, मटकी, मसूर, कुठल्या पण डाळी. सातूचं पीठ कसं करायचं मी मुद्दाम सांगत आहे, कारण आपल्या कोणाला हे माहित नाही. त्याला रात्री पाण्यात भिजवून ठेवायचं, धुवायचं, मग पाण्यात भिजवून ठेवायचं रात्री, आणि दुसऱ्या दिवशी पाणी काढायचं. मग त्याला 2 दिवसात मोड येते. त्याला छान मोड आल्यावर त्याला उन्हात सुकवायचं, म्हणजे पाणी कमी करण्यासाठी. आणि मग त्याला तव्यावर भाजून घ्यायचं, लोखंडाच्या कढईत भाजायचं, म्हणजे लोखंड पण मिळेल. आणि मग हे मिक्स करून त्याला बारीक पावडर करायची. आणि ही पावडर वोम टू टोम, वोम म्हणजे गर्भवतीसाठी, टू टोम म्हणजे दात नसलेल्या आईबाबांना, किंवा आजारी आहे, त्याला खाता नाहीये, त्याला नाकातून पोटात नळी टाकले, त्याला अन्न भरवायला सर्वोत्तम अन्न आहे वोम टू टोम. आणि कम्प्लीट फूड कसं आहे मी तुम्हाला सांगतो. त्याच्यामध्ये जवस आहे, तेलबी आहे, त्यात गहू, ज्वारी, बाजरी कार्बोहायड्रेट्स आहेत, 3 डाळी आहेत, म्हणजे सगळे कार्बोहायड्रेट्स आणि म्हणजे ग्रेन्स आणि डाळी असल्यामुळे त्यात सर्व प्रोटीन्स आहेत, नो लिमिटिंग फॅक्टर, ऑल अमिनो ऍसिड्स आहेत. मग त्याच्यामध्ये फायबर आहे, पोट साफ करतो. मग तो जेव्हा स्प्राउट होतो, अंकुर होतात ना, तेव्हा त्यात खूप विटॅमिन्स बनतात. बेसलाईन पेक्षा 40 to 400 टाइम जास्त बनतात. आणि पण ते सगळ्यात महत्वाचं आता सांगतो ते आहे, गहू ज्वारी बाजरीमध्ये अमायलेज बनतं, जे त्या पीठ पचवतं. डाळींमध्ये प्रोटीएज बनतं आणि तेलबियामध्ये लायपेज बनतं. मी तुम्हाला पुस्तकी सांगतोय का? नाही. मी ऍक्च्युअली गहू स्प्राउट केले आहेत, त्याचं पावडर केला आणि शिरा थोडा पाणी टाकून शिरा पातळ केला आणि त्यात ती स्प्राउटची पावडर टाकली ना, तर 1-2-3 तासाने ते पातळून गेलं, म्हणजे पीठ पचलं. तुम्ही करून बघा. आम्ही केलं, मी केल्याचं सांगत आहे. आम्ही डाळ केली, घट्ट डाळ केली, तुरीची डाळ, आणि त्याच्यामध्ये मूग मटकीला स्प्राउट करून त्याची पावडर त्यात टाकली 1 चमचा. 2 तासांनी वरण पातळ होऊन गेलं. म्हणजे मी केल्यावर नंतर सांगत आहे तुम्हाला. सो पाचक रस असलेलं जमिनीवर कुठलंच अन्न नाही आहे. जर आजी आजोबा एखाद्याला पॅनक्रिएटायटिस, आमच्या एका मावशीच्या मुलाला पॅनक्रिएटायटिस झाला, त्याला एन्झाईमच्या गोळ्या बाहेरून आणायला लागतात, 100-100 रुपयाची एक गोळी. जेवायला पैसे नाही, गोळ्या 100 रुपयाची. तिला मी सांगितलं की तू हे आण, मूग मटकीला मोड आण आणि वापर. पाचक रस असलेलं हे जगातलं एकुलते एक अन्न मला माहिती असलेलं आहे. तुम्हाला माहिती असेल तर सांगा. आणि फ्री आहे, घरातलं आहे. या सगळ्याची कॉस्टिंग केली मी, 100-150 रुपये किलो आहे. आणि बाजारातलं बेबी फूड 1000 रुपये किलो आहे. सो बघा याच्यामध्ये काय काय आहे. याच्यामध्ये कार्बोहायड्रेट्स आहे, यात सगळे प्रोटीन्स आहेत, याच्यामध्ये फॅट आहे, यात डीएच आहे ज्याने ब्रेन बनतो, यात मिनरल्स आहेत, कॅल्शियम आहे, मॅग्नेशियम आहे, मॅग्नीज आहे, सगळे आयर्न आहे, याच्यामध्ये विटॅमिन्स आहेत, याच्यात फायबर आहे. यात नाही असं काहीच नाही, सगळं ए टू झेड आहे. नाही हे कम्प्लीट असं दुसरं अन्नच नाही आहे. असं अन्न दूध आहे अजून, पण दुधामध्ये 100 ml मध्ये 100 ml दुधात 90 पाणी असते. त्याची साय आम्ही काढून घेतो, म्हणजे अजून पातळ करतो. तुम्ही 100 पोती दही तांदूळ घेतले, त्यात 90 पोते माती आली, त्याला त्याला माती म्हणणार तुम्ही? 90% पाणी असल्या दुधाला पाणी म्हटलं पाहिजे, पाणी म्हणून दिलं पाहिजे. या दुधाने आपलं खूप मालन्यूट्रिशन होते आणि ते इरिव्हर्सिबल होते, कारण मुलं स्टार होतात 0 to 2 मध्ये या अन्नाने. पातळ अन्नामुळे मुलं स्टार होतात, म्हणून 2 वर्षाला 10 पैकी 9 मुलं मालनरिश आहेत आज. हे आपण सातूच्या पीठाने बदलू शकतो. सो सातूचं पीठ फॉर द प्रेग्नंट मदर, सातूचं पीठ फॉर द लॅक्टेटिंग मदर अँड हर बेबी टिल बेबी इज 18 years. सातूच्या पिठाचं काय काय बनतं? तर जे जे गव्हाच्या पिठाचं बनतं आणि जे जे चण्याच्या पिठाचं, बेसनाचं बनतं, ते सगळं सातूच्या पिठाचं बनतं. ही थिअरी आहे का? नाही. गेले काही दिवस आम्ही रोज सातूचे पराठे खातो, सातूचा उपमा खातो, सातूचे आणि साखरे गुळाचे लाडू केले आहेत. सातूचं पीठ केलं, आम्ही त्याचे लाडू केले, त्याचा उपमा केला, शिरा केला, काही पण नाव द्यायला. गोड केलं की शिरा, तिखट केला का उपमा, आणि त्याचे पराठे केले. म्हणजे पोळी केली, त्याच्यामध्ये सातूचा गोळा ठेवला, त्याला बंद केलं पुरणपोळीसारखं आणि लाटला आणि पराठे केले. आणि हे सगळं खाल्ल्यावर मी तुम्हाला सांगत आहे, सातूचं पीठ दुधामध्ये टाकून पिल्यावर त्याला मीठ लागत नाही, साखर लागत नाही, काय लागत नाही, छान लागतं. कारण त्यात 7 ग्रेन्स आहेत, तर सगळ्यांची अलग अलग चव आहे त्याच्यात. खूप छानच आहे. हे तुम्ही करून बघा. आणि तुम्हाला काय सांगायचं आहे, हा हे केले आणि मग सांगितलंय. गेले 3 महिने मी हेमंत सातू जोशी नाव आहे माझं. मी सातूग्रस्त आहे सध्या. सो बघा, सगळ्यात मोठा प्रॉब्लेम आहे, शी होत नाही हा आहे. तो सातूने निघून जातो. 10 पैकी 9 मुलं मालणारी सेकंड बर्थडेला, ब्रेन वाढत नाही. हा प्रॉब्लेम सातूने सोडून जातो. माझा अभ्यास आहे, सेम वेटचे न्यूबॉर्न्स, इंडियन आणि अमेरिकन, समजा तुम्ही 3.75 किलो, 3.3 किलोचा धरा, तर त्यांच्या डोक्याचे घेर आपल्या ग्रोथ चार्टमध्ये बघा. सेम वजनाच्या, सेम बर्थ वेटच्या मुलांचं हेड सर्कम्फरन्स ॲट द बर्थ ऑफ सेम पर्सेंटाईल तुम्ही बघा. तर इंडियन लोकांचं डोकं मोठं असते ॲट बर्थ, पण ते वाढदिवसाला 1 सेंटीमीटरने कमी असते. आता मला थोडं आठवणीमध्ये प्रॉब्लेम आहे, 1 सेंटीमीटर किंवा 1 इंचाने कमी असतं आपलं डोकं, आणि ते 6 महिन्यालाच कमी होऊन जातं. हे व्हायचं नसेल तर डीएचए दिलं पाहिजे आईला आणि बाळाला. त्यासाठी सातूच द्यायला पाहिजे, बेस्ट सोर्स. सो आपण हे सगळं करूया. बरं, हा एकटं सांगतो का? नाही. युट्यूबवर व्हिडिओज बघा. शत्रुघ्न सिन्हाचा व्हिडिओ आहे की मी आणलेले सातूचे पराठे सगळे मित्र खाऊन टाकतात, सगळ्यांना आवडते. शिल्पा शेट्टी सांगते की मी छान दिसण्यासाठी सातूचं पेय पिते. तिने तिचे मेनू पण सांगितलाय की 2-3 चमचे सातूचं पीठ घ्या, त्याच्यामध्ये पाणी टाका, त्याच्यामध्ये आमचूर टाका, ते आंबट म्हणून आमचूर वापरतात, मग काळं मीठ टाका. तिने तिचा सांगितलाय मेनू. एक कोणतरी दिव्यांका त्रिपाठी दहिया म्हणून हिरोईन आहे, ती सांगते मी छान दिसायसाठी, छान राहायसाठी सातूचं ड्रिंक पिते. केवढं छान आहे ना. कृष्ण आणि सुदामा सातूचं पीठ खायचे, आपण खाऊया, बाळाला बाळकृष्ण करूया. अश्वत्थामा अमर होता, अश्वत्थामा अमर होता. त्याचे वडील अश्वत्थामाच्या द्रोणाचार्य, म्हणजे पांडवांचे आणि कौरवांचे गुरु. पण त्याच्या जन्माच्या वेळा ते गरीब होते, त्यांच्याकडे गाय नव्हती, दूध घ्यायला पैसे नव्हते. तो सातूचं पीठ खाऊन मोठा झाला आणि अमर झाला. मग मुलांना अमर करूया ना आपण, त्याला आपण सातूचं पीठ देऊया. सातूचं पीठ घ्या, त्याच्यामध्ये पाणी टाका किंवा दूध टाका किंवा ताक टाका, एवढं टाका की तो घट्ट राहील. एवढं पातळ चमच्यातनं सांडला नाही पाहिजे, एवढं पातळ करा आणि ते त्याला द्या. आणि एका मिनिटात तयार होतं. पाणी घेतलं, सातूचं पीठ टाकलं, ढवळलं, दिलं. ते 2 मिनिट जे सांगतात ना मार्केटमधला, त्याचं पाणी गरम करायला जास्त वेळ लागतो त्याच्यापेक्षा. इन्स्टंट आहे. 100 रुपये किलो, 150 रुपये किलो. बाजारचे बिस्किट सुद्धा 300 रुपये किलोच्या वर आहेत. तर आपण बाजारचं सगळं जंक फूड बंद करून सातूचे पीठच द्यायला पाहिजे. आमची पिढी ना घरी जेवायलाच नव्हतं, जस्ट बेर जेवायला. तर हॉस्टेलला 2दा जेवण जेवायचं, बाकी वेळा सातूचं पीठ खायचं. असं करून डॉक्टर झाली. माझी नात आज सातूचं पीठ खाऊन मोठी होते आहे आणि सुंदर होते आहे. आपण इडल्या करू शकतो, सातूच्या पीठात लोणचं, मसाले, सॅलड्स, फ्रुट्स काही पण टाकून खाऊ शकतो. पोळ्या, पराठे, इडल्या काय पण करू शकतो. आणि हे महिला मंडळाला करायला सांगू तर आपलं गाव पण श्रीमंत होईल. सातूचं पेय सगळ्यात छान आहे. आपण 200 crore रुपीजची कॉफी, चहा, कोल्ड ड्रिंक्स पितो, कोक पितो, त्या जागी जर आपण सातूचं पेय पिलं ना तर खूप पैसे वाचतील आणि परदेशी जाण्याचे पैसे थांबतील. आणि चहामध्ये कॅफीन आहे, त्याने पल्पिटेशन होतं, बीपी वाढतं, इरिटॅबिलिटी होते, गाढ झोप खराब होते आणि मेमरी खराब होते. कॉफी बंद केली ना तर आपल्या देशाचं खूप भलं होऊन जाईल. 1 कप चहा रोज एक्स्ट्रा पिला की अर्धा किलो वजन महिन्याला वाढतं. तो बंद करून आपण सातू पिला तर वेट गेन होणार नाही. वेट गेन झाल्यावर बीपी, हार्ट, शुगर, डायबिटीस, मरण हे होतं, हे पण चाललं जाईल. सातूला चविष्ट कसं करायचं? सातूला चविष्ट करायची काही गरज नाही, तसं छान लागतं. ज्याच्या पोटात जागा नाही ना, म्हणजे भरल्या पोटी तुम्हाला टेस्ट मेकर्स लागतात, पण 7 वस्तूंनी टेस्ट मेकिंग छान होतं. 7 वस्तू कुठल्या आहेत? तिखट, मीठ, साखर आपल्याला माहिती आहे. जिभेला 6 चवी कळतात: तिखट, मीठ, साखर. आवळा किंवा कच्चे डाळिंबाचे दाणे तुरट असतात. चिंच, आंबा आंबट असतात. आणि कारलं किंवा कडुलिंब कडू असते. या 6 वस्तू एकत्र करा आणि मेंदूमध्ये ग्लुटामिक ऍसिडचं, ग्लुटामेट हा न्यूरोट्रान्समीटर आहे. मेंदूमध्ये ग्लुटामेट असतं, ज्याच्यात ग्लुटामेट आहे ते आवडतं, म्हणून लोक टोमॅटो खूप खातात. टोमॅटो भाजीत पाहिजे, टोमॅटो सॉस पाहिजे, टोमॅटो सॉस पाहिजे, टोमॅटो केचप पाहिजे, चटणी पाहिजे. ते 6 वस्तू आणि टोमॅटो एकत्र करा, त्याची चटणी करा, त्याचा सॉस करा, त्याचा सिरप करा, ते ड्राय करा, पावडर करून ठेवून द्या आणि कशात पण टाका. तो मातीत टाकला तर लोक माती खातील, सातूचं पीठ खातील काय. आणि पेप्सीच्या जागी याचं पेय करून विकायला भरपूर पैसे करूया आपण. आपण सगळे करूया, एक शेअर घ्या त्याच्यामध्ये, आपण करूया. तर असं मला सध्या मी एकदम सातूमय झालेलो आहे. तर जरूर तुम्ही आज घरी एक वाटी मागवून घ्या. 7 गोष्टी. कुठल्या 7 गोष्टी? जवस, गहू, धान्य, कुठले पण धान्य तुम्हाला जे मिळेल ते. गहू आहे, ज्वारी आहे, बाजरी आहे, नाचणी आहे, डाळी, शेंगदाणे आहे, काय नावं तुम्ही घ्या, चणे, मूग, मसूर, मटकी, वाटाणे, जे काय ज्याला स्प्राउट होतं सगळं स्प्राउट करा. स्प्राउट झाल्यावर ड्राय करा. ड्राय झाल्यावर त्याला रोस्ट करा, म्हणजे डिहायड्रेट करा बेसिकली, आणि पावडर करून मिक्स करून ठेवून द्या. पाहिजे तर प्रत्येकाला थोडं थोडं घेऊन तुम्हाला कुठली चव आवडते ते करा. पण आपण सगळ्यांनी जर आपल्या तालुक्यामध्ये होम टू टर्म सातूचं पीठ प्रमोट केलं ना तर आपला तालुका छान होईल आणि भारतात नंबर 1 होईल. केरळच्या पुढे जाऊ आपण, पालघरचं नाव बदली करून टाकू. मोदी आले पाहिजे सत्कार करायला जयश्रीबाईंचा अध्यक्ष म्हणून, किंवा सबसिक्वेंटली युगाली झाली तर युगालीचं करूया. आणि मग हे खूप छान होईल. मला किती वेळ झाला माझं लक्ष नाही घड्याळाकडे. झाला ना हा, माझी वेळ झाली का?
हो सर, हा फार झालेला आहे. आपण थोडं शॉर्ट ऑफ टाइम सुद्धा आहोत, त्यामुळे
आय एम
आपण
हॅपी, आय एम हॅपी टू
पटकन
फिनिश.
आटोपतात
आय एम
जाऊ.
ओव्हरजॉयड टू फिनिश. मनापासून आभारी. थँक्यू. माझं कोण ऐकत आहे, तुम्हाला खूप खूप धन्यवाद.
थँक्यू सर, खूप छान झालं तुमचं सेशन. आणि तुमचं जे इनोव्हेटिव्ह बलून ऑर्कायडोमीटर आणि बलून स्पायरोमेट्री आहे, ह्याबद्दल तुम्ही नेहमीच सांगत आलात. त्याच्यानी आम्हाला खूपच म्हणजे फॅसिनेटेड आहोत आम्ही ऑलरेडी. आणि आज जे तुम्ही सत्तूच्या पिठाचे जे गुणधर्म सांगितले, ते निश्चितच सगळ्यांनाच आवडलेले आहेत. आणि आमच्या ज्ञानात याने नक्कीच भर पडलेली आहे. सो थँक्यू सो मच सर.
आता माझा
तुमचा
फुगा
खूप खूप धन्यवाद.
फुगवला, दोराने बांधला, हवेत उडवला. असं होणार आहे. थँक्यू
सात्विक
युगाली.
सातूचे पीठ सर्वांनी खावे, हे आपण एक याचा पालघर अकॅडमीचं आता ब्रीद वाक्य ठरवायला पाहिजे. आणि सगळ्यांना ते सांगायला पाहिजे, जसं सर सांगतात तसं.
आपण ब्रीद वाक्याच्या ऐवजी ईट वाक्य करूया.
ईट वाक्य. हो.
विल ब्रीद सातू, चालेल, ते पण चालेल. We'll drink
आजी
सातू,
आणि
we'll eat
नातू
सातू.
खा सगळे सातू.
क्या बात आहे.
अरे कोकणी आलंय छान गोड.
एकदम छान असं ताई. खूपच छान आहे. एक्सलंट. आय एम सो हॅपी. चक्क 16 लोकांनी ऐकला. व्हेरी गुड. सगळ्यांना थँक्स. तुम्ही सगळे करा सातूचं पीठ. आपण राष्ट्रीय अन्न करूया सातूला.
हो नक्कीच.
तर
आपण
एक व्हिडिओ बनवून सगळ्यांना पाठवा, म्हणजे मग तो
तात्काळ.
किती प्रमाण काय
आज्ञा
घ्यायचं ते
आज्ञाप्रमाण
सांगता येईल.
तात्काळ. डन. मी व्हिडिओ पाठवतो, तुम्ही सगळ्यांना फॉरवर्ड त्याला व्हायरल करून टाका.
नक्की.
चला, डन.
डॉक्टर मनीष कुमार, कॅन यू प्लीज म्यूट युअर
केलं
या
केलं मॅडम, केलं.
युगाली.
येस.
पल्लवी, तुमच्या ऑफिसमध्ये आलं की सातूचं पाजा काय?
नक्की सर, नक्की.
आपण पुढच्या सेशनकडे वळूयात. आपला नेक्स्ट जो टॉक आहे तो डॉक्टर जयश्री देशपांडे मॅडम, आपल्या पालघर अकॅडमीच्या प्रेसिडेंट, त्या आज बोलणार आहेत द टीन स्लीप क्रायसिस या विषयावर. तर आपण वेळ न घालवता त्यांच्या टॉककडे वळूयात. मॅम, तुम्ही कंटिन्यू करा.
पल्लवी ताई, कॅन यू प्लीज शेअर द स्लाइड्स?
Madam, is
Thank you.
this
I'm Dr.
visible?
Jayashree Deshpande, and today I would like to talk on teen sleep secrets and how to rest, reset, and revitalize. Next. Do you know how much we sleep? As an adult, we sleep almost 25 to 30 years of our life in sleep, or in a child till the age of 18 years spends 8 years of his life in the sleep. And infants almost 2/3 of his life in the sleep they spend. Next. So sleep is an active process, is not a passive process. आपल्याला खूप कष्ट घ्यावे लागतात झोपायला. आणि it's a complex process, and it interacts, many hormones interact with each other. And it is actually a process where we suppress the arousal mechanism. It's not a passive process. Next. So there is a homeostatic system inside our body, so which drives to sleep after long periods of wake, or we drive to wake after a long period of sleep. This biological drive is to maintain the equilibrium between sleep and wake mechanism. Next. This homeostatic system is mainly run by adenosine. This is called as sleep switch. The adenosine accumulates with the activity and increases the sleep propensity. Caffeine is the most important thing which actually suppresses the sleep by blocking the adenosine receptors, and it promotes wake. So we should not take caffeine, as sir said, as coffee. We should avoid it. Next. So there is this complex mechanism is there where the ventrolateral preoptic neurons, with the help of neurotransmitter orexin, acts on the this nucleus which is there in the posterior raphe of hypothalamus, and we have this mechanism allows sleep or transition of wake and transition to sleep occurs through this ventrolateral preoptic neurons. Next. So we all know there are 4 pillars of sleep. This is regularity, continuity, quantity, and quality. Regularity is always we should stick to the sleep schedule. Continuity is very important every day, and we have to every night, rather, we have to sleep through a specific time. Quantity is from 7 to 9 years, we should get sleep, and quality is also important. Next. In adolescent, what is different? Actually, the developmental shift is there in circadian rhythm in adolescent. This is likely driven by the new maturation and modification of the brain anatomy. As we all know that there is pruning is occurring in the adolescent brain. So there is a marked reduction in EEG amplitude also due to increase in the white matter volume for adolescent, and this leads to the delayed circadian rhythm pattern in adolescents. This is actually because of this sleep pressure is slow in adolescent, and they sleep in the late night and wake up in the like late in the early in the not in early in the morning. They sleep late and wake up late. Next. Adolescent sleep needs minimum 8 to 10 hours. And this, as I have told you, that is they have a later circadian rhythm and slowed hemostatic sleep drive. And it's actually, they have many problems in the adolescent period where food habits are changing, stress is there, new hormones are coming up, and this hormonal and the stress, social stress is there, anxiety is there, career decision is there. So sleep is always hampered. They may suffer from insomnia or some circadian rhythm sleep disorders. Next. So what are the benefits of sleep? Sleep actually acts on our amygdala. It's getting good night sleep regulates the function of amygdala, and there's less unnecessary fear or stress or anxiety and aggression is there, which leads to more emotional stability. Next. Next slide. So this is a normal scenario of a teenage girl or boy on your couch in the morning period, early morning period or afternoon. This is the normal scenario. Next. Coming to common cases which we face usually in adolescent phase, this is a 14-year-old girl who has a difficulty in falling asleep at night. She does her schoolwork and goes to bed by 10 p.m. with her cell phone and a TV with a low volume. She usually sleeps by 11 p.m. or 2 a.m. on weekdays, and she may sleep till 11 a.m. on weekends. Actually, she wishes to sleep early but cannot. Also complains of daytime sleepiness. Next. So what do you think is the problem with this child? She has excessive sleepiness is due to insufficient sleep. This is secondary to delayed sleep-wake phase disorder, which is normal and physiological in adolescent. So this is not this child does not need any treatment, only some lifestyle modulation is to be done. This is pathological if delay in the sleep phase with inability to fall asleep or wake up at a desired time for at least more than 3 months. So then only we will intervene. Otherwise, we will counsel the parents for the lifestyle changes. This is a case 2. This is another case, 14-year-old with history of snoring since 6 to 8 months. She has daytime lethargy and irritability. Weight gain of 10 kg is there in 1 year. She sleeps around 12:30 a.m. and gets up at 7 a.m. for the school. But she usually takes naps of 1 to 2 hours after returning from the school. She has a history of obesity, hypertension, and type 2 diabetes in her family. And her Malapatti score is of 3, of tonsils is 2 plus. She also has acanthosis nigricans present. Next. So what is your clinical impression? What is the importance of history of snoring and how you will proceed for such case? Next.
Jayashree,
when
can I
you
ask a question?
Yeah.
What is Malampatti score?
Malapatti score is for the tonsillar enlargement and it is taken as 1, 2, 3, and 4. That just visible tonsils, slightly enlarged tonsil. Third is like they are kissing tonsil, and fourth is like they are blocking full throat. We can score this on clinical basis.
Thank you.
Yeah. So when you suspect obstructive sleep apnea, we have to see about the nighttime symptoms as well as daytime symptoms and also the physical findings. Nighttime, you may have snoring, apnea, or awakening. Nocturnal enuresis history, always we should ask. Then in daytime sleepiness, like daytime sleepiness is there, or morning headache history is always significant. And scholastic backwardness is another significant history. On physical examination, we have to see whether BMI is higher, adenoid facies is there, adenoid enlarged tonsils are there or not, or even craniofacial abnormalities or any syndromic child is there. Then we have to suspect whether the child has obstructive sleep apnea or not. Next. So in this case, we have to advise again the lifestyle changes. Since she has gained weight, we have to advise about the diet and exercise pattern. Counseling of mother is to be done. And ENT evaluation, as you have asked about whether any obstruction is there because of adenoids or any pharyngeal problem or tonsillar things are there. Here we can do DICE. It's a drug-induced sleep test, endoscopy test, where we can see whether any obstruction is there in the oropharyngeal cavity. And if at all anything is detected, we have to treat it. Like if tonsils are enlarged, we have to remove them, adenoids enlarged. We can give intranasal corticosteroids for 3 months and see the results, whether the obstruction is reduced or not. And if at all, if the child has everything normal but still has snoring, with polysomnography score of apnea, hypopnea index more than 5, then we have to offer CPAP treatment for this child. Mainly 6 months we can give this CPAP treatment and decide further whether it is required further or not. Next. This is the third case with parents of 8-year-old child complaints of disturbed sleep because of kicking of their child in the bed. Next. This is called as restless leg syndrome, which is urge to move your legs, and it is rest induced. It gets better with activity, and in the evening or in the night, it is worst. Next. The treatment is usually non-pharmacologic. Applying hot or cold packs is important. We should avoid caffeine and antihistaminics in these children. And very important association is seen that this children with anemia has this restless leg syndrome. So we should give iron supplementation to these children who complained of this recurrent movement of their leg, and because of that, sleep disturbances. Next. So this nutrition is also very important. As sir said, there are many vitamins or minerals which affect our sleep. mainly vitamin D or vitamin C's, which is their deprivation, may lead to sleep deprivation. And nutrients such as tryptophan-rich food or antioxidants can even melatonin-rich food is there, and micronutrients are there. So fruits are there, which positively affect the sleep quality. So we should give or find out whether any micronutrient deficiency is there for the children, mainly adolescent, who has craving for the junk food. Next. So this is another thing which is very important, that circadian rhythm in our body is given to us by our parents. It is the first 2 years of life our body develops the circadian clock inside our body, and it is with the discipline or regularity this clock is set up in our body. And this is the most important thing I think every parent should give to their child, that the regularity of life is maintained by having this discipline. Next. Sleep hygiene is one of the very important thing, and you can associate it with dental hygiene. Sleep hygiene, the temperature of your room is very important. You should not keep any books or a laptop or phone on your bed or where you sleep. And I think they should avoid the light which is there coming up from small switches where we like have switching our mobile phone inside our bedroom should be avoided. Charging the phone inside our bed should be avoided. Thus, even small light can disturb the melatonin production. Next. So parents are the role model for everything, for sleep, food, and behavior. Next. This is an important thing, like Beers is a sleep screen test for every child or adolescent. We should ask this Beers history. This is bedtime problem is there or not, excessive daytime sleeping is there, awakening is there or not in the night, whether it is regular and duration of sleep history is to be done, and sleep disorder breathing present or not. From the adolescent as well as parents, we should ask these questions in every patient. I think every child should have this sleep history of Beers in your case paper. Next. So there are many short-term as well as long-term consequences of sleep deprivation, and we all know that stress is one of the things. Fragmented sleep result in increased autonomic sympathetic activation, and which may result into cardiovascular, psychiatric, or mood disorders. Next. Another thing is the somatic problem. There was a study done called as Finnish study of adolescent, which shows that prevalence of sleep problem in adolescent was almost 27%, and it is increasing day by day with the mobile phone addiction. This is always associated with psychiatric symptoms and substance abuse in adolescent. Next. Consequences of sleep disruption include poor mental health, anxiety, depression, and even, as we say, that poor academic performance is there. Consumption of drugs is also one of the things which we should then, and the suicidal tendencies is also associated with sleep deprivation. Next. There are many long-term consequences like cardiovascular effect, as we have seen, and there is a score called as PSQI score, where we have this questionnaire, formulated questionnaire is there, and we have to correlate this with high cholesterol associated with BMI, or blood pressure is also raised because of the glucose metabolism, insulin resistance, and inflammation. Next. So as I had told you that impaired insulin sensitivity is associated with sleep deprivation, and there is a relative risk of developing type 2 diabetes mellitus was almost 1.84% more with children who have sleep deprivation. Next. Again, the prevention of metabolic syndrome or increased incidence of PCOS in girls is seen who has a sleep deprivation. Next. This is again an important thing that even sleep deprivation may lead to increased risk of cancer because melatonin has other important properties like they have DNA repair or inhibition of tumor growth factor is there in sleep, and it's a potent free radical scavenger. So we should avoid the sleep deprivation which is there in adolescent. Next. Again, gut metabolism or gut microbiome is studied. Previous slide. Gut microbiome is studied in detail because of sleep deprivation. All gut microbiota is changed. So we have to avoid all this sleep deprivation in adolescent, and this is called as 10-3-2-1-0 sleep rule. 10 hours of no caffeine before sleep. So if you are sleeping at 11 p.m., by 1 p.m. in the afternoon, you should avoid caffeine or tea. After that, it may hamper your sleep. 3 hours of before food, there we should not take food. 2 hours, no more work, which causes like stimulation of our frontal lobe. 1 hour before bed, there should not be any screens, and we should avoid the alarm system to wake up. That is snoozing in the morning is very dangerous. It disrupts our brain waves, and that is very important that we should not use alarm for waking up. Rather than we should use this alarm to set our sleep timing. So you will hit 0 times the snooze button. Next. So thank you again. We are able to reset, rest, and revitalize and decide and make this adolescent kids with resilience. Thank you so much.
Very nice talk, Jayashree. Thank you.
Thank you, Anjali. Thank you.
But this 10, 3, 2, 1, 0, even we find difficult to follow.
No, we have to.
Yeah. We have to do it ourselves before we tell others.
From today onwards. So that
Okay.
was the reason I shown that parents photo.
Yeah.
Parents are role model.
So even grandparents are.
Yes, definitely.
Jayashree, one question.
Yes, sir.
What about the role of drug in restless leg syndrome and sleep disorders in pediatric age group?
What is the?
Role of medications, because nowadays a lot of
Yeah,
people
sir,
are prescribing
there are.
gabapentin, antidepressants, and they are getting good results. So, do we use in our clinical practice as a adolescent students or adolescent age group?
Sir, for adolescent, melatonin is tried and it is given 3 to 5 milligram 1 or 2 hours before the sleep timing, and it actually induces sleep in a natural way. There are not much side effects with melatonin. With antidepressant and anti-anxiety drugs or sleep-inducing medicine, they may cause addiction or they may have the dose-related issues. So unless we show this thing to the psychiatrist, it's a teamwork, like a pediatrician and a psychiatrist should get involved if the child has got anxiety or depression, and then we can definitely give such drugs if required. If the intensity of insomnia is that high, then we have to give. And many children with this syndrome or neuromuscular disorders or craniofacial abnormalities, we are like these drugs are tried.
Because a lot of people, are, especially psychiatrists, are giving gabapentin to restless leg syndrome. Maybe in an adult practice, but I don't seen in for a pediatric age group whether these drugs are used much.
We give iron only, sir, for this
We
restless
we
leg
restrict to
syndrome.
iron at the most melatonin.
Yes,
Because I think
melatonin.
melatonin also in our I think the last discussion few of our CMEs, some
Hmm.
pediatricians were using that drops, melatonin drops are available
Drops are
for
there. Yeah.
newborns. So we have
Yes.
raised the issue about that also, I think.
I want to share that I get very bad restless leg syndrome if I take Benadryl or if I take CPM. And I don't have to take any medication. I just have to stop taking that medication. So
So this is drug induced then.
yeah. So we prescribe CPM to so many children, and then we find that they are restless. And so we really don't know whether they get restless leg syndrome. So it's a good point you brought up.
Another thing, Anjali, I think you have raised this regarding CPM and lot of cough mixtures contains phenylephrine, CPM, and
Yes.
these are the drugs actually interact with the MAO inhibitor, a lot of drugs, and there is a lot of interaction. And I especially come across babies, especially between age group of 6 to 2 years, when they are given heavy doses of all cough mixtures, they are so irritable. It's very
Yes.
difficult. And then what I do, I stop the medication, and within 12 to 24 hours, babies are quiet.
Comfortable.
So I think these CPM, phenylephrine are irritants, and they must be creating havoc to our,
Children.
especially
Yes.
6 months to 2 year.
Yes.
And another thing is all these drugs ideally should not be given in TID or QID doses. I personally feel even if you give twice daily, morning and night time, they are sufficient.
Very good point, Suryakant. Even I give only twice a day now. But I don't give CPM to less than 2 years or phenylephrine also.
Yeah.
We can give this as once in a night time, whether they usually induce sleep also. So that is also one of the way you can reduce the dose. But still, we should avoid all this combination of drugs. That's very important. Thank you so much. Thank you.
Dr.
Yugali?
Hemant is there. Dr. Hemant, I think your
Dr.
call.
Hemant is there, but I think he is on the verge of dry. He is traveling.
Okay, okay, okay. It's okay.
Yeah. Dr. Yugali? I think Yugali is not there. Maybe her network is unstable. So I request Dr. Praful Rane to present an interesting case. Dr.
Okay, sir, ma'am.
Praful Rane,
Yeah.
Yugali is there.
Yes, ma'am.
Hello,
So I
Yugali.
think
Yeah.
network
No
connectivity
issue.
issue, I got disconnected.
Yeah,
Yeah,
no
I am
problem.
also facing
I
some.
was requesting Dr. Praful Rane, a senior pediatrician who is practicing in Vasai, in the intensive care medicine,
No,
pediatric care.
I am general pediatrician.
Okay, but he has a very good intensive care unit in Vasai West. So we welcome Dr. Praful Rane. You can share your screen, or you can like go ahead like Dr.
Some-
Hemant Joshi went ahead. Yeah.
So, 1 sec. मीन आय नीड म्हणजे पीपीटी ओपन करून स्क्रीन शेअर करायची का?
Yes, you are a co-host now. So otherwise you
Oh.
can send the PPT to to Mrs. Pallavi if she is ready.
1 मिनिट मॅम.
If you are not ready.
सूर्यकांत नमस्कार.
Meanwhile, तुला हेमंत
बोल
सत्तू कोणी खाऊ नये हा मला एक प्रश्न होता कारण देर आर सम रिपोर्ट्स
हा
स्पेशली सत्तू शुड नॉट बी गिवन टू द चिल्ड्रन बिलो एज ऑफ 2 years.
त्यांना क्षमा करून टाक.
आता दिसतंय स्क्रीन वरती?
ओके.
कृष्णाने सत्तू खाल्लं, अश्वत्थामाने खाल्लं, माझ्या नातीने खाल्लं, मी खाल्लं आणि आम्ही छान आहोत.
नाही तुम्ही मोठे आहात.
अरे माझ्या नातीने पण खाल्लं ना 6 महिने ते 2 वर्ष, तिच्यापासून मी शिकलो.
ओके गुड.
म्हणजे आय रिव्हिजिटेड सत्तू बिकॉज ऑफ हर.
ना सत्तू इज अ फूड ऑफ आय थिंक बिहार अँड मगध.
आपण गुलामगिरीमध्ये वाया गेलो.
हा?
सत्तू आपला सांस्कृतिक 5 लाख वर्षापासून आहे सगळ्यांचा आहे. आणि
नक्कीच.
6-7 वस्तूंचा हे पण विसरलो.
हो हो.
आणि
आणि
आपण बिहारच आपला
सत्तूचे लाडू
पण
अगदी
आता
आधीपासून भेटायचे.
आता त्याच्याबद्दल बरंच संशोधन चाललंय.
हो, आय एम सो हॅपी अबाउट इट.
ओव्हर सत्तू. स्क्रीन विजिबल आहे सर्वांना दिसतंय
हो,
आणि
छान
आय एम
ब्लू
ऑडिबल.
पर्ल्स. येस, ब्लू पर्ल्स.
Okay, okay.
We
गुड.
can
So
see you.
this
Yes.
is
See the
yeah. So this presentation is named as blue pearls because of certain reasons. So I will just begin with the case presentation. So this baby ABC presented on day 25 of life with complaints of poor feeding, vomiting, abnormal posturing of limbs with vacant stare, and there was a bluish discoloration of the peripheries, and there was some central cyanosis also. Uh, so in active convulsion, we anticipate those things are going to happen. So on examination, pulses were well felt, heart rate was 130 per minute. Baby had active convulsion, saturations level were 80%. Rest systemic examination was within normal limits. So we initiated the treatment, supplemental oxygen, IV midazolam followed by levifil phenobarbital to control the convulsions. Blood samples were taken for the basic evaluation, sepsis screen, calcium, electrolytes. So the convulsions were controlled in due course of time with 2 anticonvulsants. Then the secondary assessment, finding of the cause of the convulsions and all these things. So in spite of the supplemental oxygen being provided at the 6 to 8 liter per minute, the SpO2 on the pulse oximeter was hovering around 85 to 88%. Respiratory distress was not so significant. On cardiovascular examination, there was no audible finding. So at this point, with the supplemental oxygen, when the baby's saturations are not improving, we consider the differential like cyanotic congenital heart diseases, as in like failed hyperoxia test, even after supplemental oxygen, pulse oximeter, saturations and all these things are not improving. Another respiratory etiologies, the chest X-ray was done, which was normal. Neither were there any respiratory findings at that time. And other possibilities, sepsis, meningitis, those, but that still does not explain this non-response to the oxygen in this baby. So the sepsis workup was done for this baby. Sepsis was ruled out. Considering the age of child, CSF was analysis was done, that was normal. So only thing that baby had pallor, hemoglobin was 7.2 gram%. Rest all the investigations were near normal. So next, the blood gas was taken for this baby. So in this blood gas, we found that oxygenation in the blood gas is near normal. PO2 was 145, saturation in the blood gases were 99%, and rest of the investigations were like near normal, mild acidosis that is anticipated in this. So at this point, we were standing like there is low SpO2 in spite of high supplemental oxygen on pulse oximeter. And on the contrary, on the blood gases, which are showing the normal oxygen parameters on blood gas. So other possibility is a faulty pulse oximeter, so which with the another pulse oximeters also. So it was almost the same pulse oximeter saturations everywhere. So when we are standing, looking at the algorithmic approach for treating this case, like it's a baby with convulsion, we are protecting the airway, looking for the airway breathing circulation, giving the antiepileptic drugs to control the convulsions, and then finding out the etiology. So sepsis, meningitis, those things are first on the priority. So those things were done in due course, but this finding of low SpO2 on the pulse oximeter, in spite of whatever oxygen, supplemental oxygen been given, and on the contrary, the normal oxygen parameters on the blood gases. So, so hardly any differential left for this kind of finding. So, failed. We talked about the cyanotic congenital heart diseases. That was not there. 2D echo was normal. X-ray was clear. There were no other contributory things. So this is seen in some of the condition called methemoglobinemia. So this methemoglobinemia is characteristically seen in the two types, the acquired kind of and the congenital kinds of methemoglobinemia. So looking at the age of child, 25, 26, I'm a month-old infant, and not having any history of exposure of any kind of nitrite-containing drugs or any kind of medications, the likelihood of only congenital methemoglobinemia was very high. So how to confirm this diagnosis? So there are certain places where the co-oximetry is done along with the blood gas. They find out the different percentage of the hemoglobin lying in the body. So for this baby, I mean, I inquired around. The co-oximetry was not available in most of the places, like Cardinal and other places. So the heparinase sample was sent for the methemoglobin percentage estimation. So the methemoglobin percentage in this baby was 11.5%. Contrary to our normal dynamics, the methemoglobin that is normally seen in every one of us, but it remains less than 1.5%. So in this baby, it was a methemoglobinemia that was causing these findings. So coming to the treatment part. So as we discussed, congenital methemoglobinemia was more likely. So methylene blue injection is used in certain cases, but it is more so useful in the acquired causes of the methemoglobinemia. Other things, when the methylene blue is contraindicated, as in G6PD deficiency or the congenital methemoglobinemia, ascorbic acid, multiple studies has shown the role of ascorbic acid. So intravenous prescription can be given, as well as the multiple studies mentioned, like in the neonates and all these things, 5 mg per kg, 6 hourly can be continued. So that helps in converting this methemoglobin to other form and makes the more ferrous form available. So treatment wise, methylene blue, it has more role in the acquired causes of the methemoglobinemia. So this baby, we started on the ascorbic acid. We gave the blood transfusion, and over the time the saturations and all these things improved, and baby was discharged home on the anticonvulsant and the ascorbic acid. Okay, so I will keep this rest of the slides for the discussion pertaining to methemoglobinemia, and how do we see this, how do we approach it, and we'll keep the things for open house discussions. So in this case, the congenital causes was more likely. It's rare. It can be happening because of two causes, either the defective enzyme or defective hemoglobin. So defective hemoglobinopathy is like doing the this thing, HB electrophoresis is quite challenging in this age group, and sometimes the reports are not so reliable. And enzymopathies, so the most common cause for this kind of congenital methemoglobinemia is cytochrome B5 reductase 3 deficiency. So it is mediated by the CYP3 gene. So with the at this point, I involved the hematologist in the care. What can be done? How can we approach this case? How can we personally say that what enzyme deficiency is there? So he advised about the National Institute of Immunohematology. So they do this test at the bare minimum cost. So the samples were sent to NIH. It's in 13th floor KEM. So this baby was deficient into this cytochrome B5 reductase levels. So the normal cytochrome B5 reductase levels in the bloods are around 30 to 40 international units per gram of hemoglobin. This baby's cytochrome B5 reductase level was only around 18, 17, 18 international unit per gram of the hemoglobin. So far we got the diagnosis like is a congenital methemoglobinemia due to cytochrome B5 reductase deficiency. So what happens, and this we'll talk about the methylene blue. So it is usually said that when baby is blue, we have to inject something blue when we are confirming the diagnosis of the methemoglobinemia. So before we give methylene blue to the any patient, we have to make sure that subject is not G6PD deficient. Because what happens, this pathway is not normally present. It becomes activated when the some reducing agent like methylene blue is given inside the body, and it requires the NADPH for the activation of the pathway. So this NADPH is produced by the G6PD pathway. So if the G6PD deficient subject is there, so contrary, it can cause the very severe hemolysis in the patient. So that methylene blue should be avoided if the patient is G6PD deficient. Other modalities of treatment is ascorbic acid, and the rest supportive care we have to continue. So in spite of though oxygenation is not improving, you have to continue the supplemental oxygen and all. And secondly, the effect of it, it's a percentage of methemoglobin how much it is getting accumulated in the body, the signs symptoms will be manifested accordingly. If the methemoglobin percentage are between 10 to 20%, it can cause many of the time asymptomatic these cyanosis and all these things. If it exceeds around 30 to 40%, it can cause the convulsions and all these things. And the methemoglobin percentage, if they are building above 50 to 60%, it can cause the life-threatening situations. So the hemoglobin that is normally seen in our form is a ferrous form. So ferrous form is the lower oxidation state. So it has the ability to bind with oxygen and carry the oxygen to the tissues, to our vital organs. So, and normally the methemoglobin percentage is around 1% to 1.5%. So unfortunately, in methemoglobinemia cases, the percentage of the methemoglobin increases. And in congenital causes, which is because of enzymopathy of this cytochrome B5 reductase, the normal machineries which are working in our body to convert the methemoglobin back to the hemoglobin level is defective. So the methemoglobin goes on accumulating, and it can cause this kind of problems. And so finally, in this case, it was cytochrome B5 reductase deficiency, which was documented. The functional activity was almost the 50% of normal. And further confirmation, yes, we have now in the modern medicine, like whole exome sequences or the NGS, those studies can be done, and that can find out whether the gene which is responsible for this enzyme is defective or not. So it is inherited in autosomal recessive pattern. There was history of consanguinity also in these parents. So discharge the baby on the supplemental vitamin C, levetiracetam. Advise for the close follow-up. Explain them what crisis can happen, and further genetic workup that we told them about. It could be required, and it can help us delineate the things. The second thing. Having given the blood transfusion, there is some restriction about doing the genetic workup immediately. So we'll give some interval and meanwhile follow up the child and look after the things. So how long to give supplemental vitamin C? There are against the conflict in that we have to give it when there are the crisis moments and all these things, and then we can take it off. Keep monitoring for these things. Explain the signs symptoms to the family, and then follow up closely. So the treatment wise, this baby, we have to treat the tell the parents about what signs symptoms can happen, what methylphenidemia can do. Yes, definitely there were some things which were not completely explainable by the amount of methemoglobin. If we look at the literature, that methemoglobin which is required for causing convulsions and other things are around 20 to 30% or above that can cause this kind of convulsions and other things. But there are always some exception to every rule everywhere. And secondly, we didn't even, find any cause for the convulsion of baby. The electrolytes, calcium, everything was normal. Spinal tap, CSF was normal. So finally, we concluded like it could be because of some hypoxia, which has been caused by this methemoglobinemia for maybe for the little bit longer time. That has called the hypoxis convulsion in this baby. So so the entire workup is at pending, but yeah, we got the basic workup like methemoglobin levels, then the levels of cytochrome B5 reductase, those were deficient, and we are following up the baby. The genetic workup is pending, that can further throw light on this. So nowadays they are saying like in certain places they are doing it at the bare minimum cost under the ICMR project and all. So we'll inquire about it and try to get the genetic workup done for that baby. Looking at the incidence of this methemoglobinemia, particularly the methemoglobinemia per se, the acquired methemoglobinemia is also very less, but certain times some nitrate containing drugs which are taken in the overdose quantity, the aniline dyes and all these things can cause this kind of methemoglobinemia. So that is the acquired cause. And congenital causes, there are only two things, enzymopathies and hemoglobinopathies. So that causes this kind of things. And with this, I conclude the things, and we can.
Excellent case.
So, thank you, ma'am. Thank you.
Thank you, sir.
That's
It was
it.
a very
Stay
nice
curious, stay
testimony.
blue. Stay curious, stay blue. That's good.
Code blue.
Good.
Praful, I just wanted to ask you, when you did that initial test of finding out that the methemoglobin was 15%, where did you send that test?
I sent to Metropolis.
I
Initially,
see.
I inquired at cardinal graces and all whether they are doing the co-oximetry in the blood gas. If they are doing the co-oximetry in blood gas, they will report it immediately. I mean, as the time required for running a blood gas, that much time is only required to see the hemoglobin. But I didn't get any response from them. So inquired at places. So Metropolis said yes, they are doing the methemoglobin levels.
So you have to send in a heparin blood.
Yeah. So in the
Heparin bulk.
heparinized bulk, yeah, heparin bulk. So
Excellent.
they also responded relatively quickly, only within some couple of hours. I mean, by night, evening, they replied back that yes, methemoglobin is high.
And how did you give the vitamin C, IV or
No,
oral?
oral, ma'am. So I just reviewed the literature. उन्होंने everywhere they had said कि 5 mg per kg, give it 6 hours.
And what about methylene blue? Do you know how it is given?
I procured methylene blue. म्हणजे लुकिंग ॲट ओव्हरऑल पिक्चर अँड ऑल दिस थिंग मिथिलीन ब्ल्यू मागवलं होतं मुंबईमधनं सम प्लेसेसमधनं. पण त्याच्यामध्ये कसं होतं की ॲक्वा अँड देन अगेन आय डिस्कस विथ हिमॅटोलॉजिस्ट अराउंड ही सेड की जर कंजेनायटल कॉजेसचा आपण विचार करतोय तर मिथिलीन ब्ल्यूचा एवढा रोल नसावा.
It's only
आणि या सो but I just procured in case of any crisis or any something, if required, we can at least give methylene blue to that baby and see.
very nice. So basically, methemoglobinemia can occur because of enzyme deficiency and hemoglobinopathy.
Yeah. If you are talking about congenital causes, acquired causes, so it is like our normal enzymes as a method that is getting exhausted. So methemoglobin builds up in the body in acquired causes. I mean, someone is exposed to the aniline dye workers and all these things, some nitrite containing drugs. Though these things can cause the acquired methemoglobinemia. So here the catch in the diagnosis, I mean, the only thing is like the discrepancy in the oxygen level measured by your pulse oximeter and your blood gas oxygen tension.
चेक करायचं
So,
होतं टेरेस असं सांग.
so we usually don't get that. No, it should go both the things hand in hand. Like if there is low oxygen in the pulse ox, there will be low oxygenation in the this thing also. So so basically methemoglobin, the problem, what is happening that there is oxygen in the blood, but our body is not, the hemoglobin is not ready to dissolve it to the tissues. So what we used to learn in our physiology days, the oxygen dissociation curve. So methemoglobinemia shifts the oxygen dissociation curve towards the left side. So it keeps the oxygen with itself. It doesn't release it to the tissue. And then the tissue hypoxia of the different intensities can cause the different kind of these things. Maybe या बच्चूमध्ये मेबी त्याचं एज एवढं कमी असल्यामुळे मेबी ॲट द लोअर लेवल्स ऑफ मेथिमोग्लोबिनिमिया त्याला कन्व्हर्जन झाले असावे. कारण बाकी सेप्सिस नव्हतं, मेनिंजायटिस नव्हतं, UHG cranium was normal.
And how you had done the test of this enzyme which you said at KEM?
Yeah. So for that, म्हणजे Dr. Amit Jain, he only suggested that we can get this test done at NIH, National Institute of Immunohematology. So it is located in KEM. So just communicated with those people. So they did the needful and reverted back.
I remember one patient who was on Dapsone, and he had this dissociation curve, and he was showing low levels of oxygen on pulse oximetry. So it was one of the cause for his low oxygen level. That was in COVID times. Yeah.
So Dapsone is known medicine to
One
cause
of
the
the cause. Yeah.
yes. आणि आधीचे काही अक्वायर्ड कॉजेस आहेत त्याच्यामध्ये त्यांनी सांगितलं की मदर वॉज ऑन डॅप्सोन अँड द बेबी डेव्हलप द मेथेमोग्लोबिनिमिया.
Yes.
Some other case, not this child.
नाही, नॉट दिस वन.
In acquired.
सम अदर केस. नाही, आता म्हणजे ही केस आल्यानंतर देन आय स्टार्टेड आस्किंग
Reading up.
AI, ChatGPT, what are causes and all, तेव्हा समजल्यात काही गोष्टी.
So 30 years ago, when we were new in practice, not 30, 40 years ago, Vasai station la some child had some drink which was colored and then developed methemoglobinemia and was admitted with us. I don't remember the exact details, but I think we just gave, like you did, oral vitamin C, because even if you do get the methemoglobin, I mean, you get the methylene blue and this, we are not sure whether it is sterile and whether it can be given, because we have never used it. But I remember even when I was a houseman in adult, we have given IV vitamin C.
Anjali,
What is the dose
we
we
can
should
give
give?
actually methylene blue IV in Boisar MIDC Tarapur. There are various industries which use aniline dyes for
Yeah.
paracetamol and various drugs.
Okay.
And about say 15 years back, a lot of patients used to come with methemoglobin levels very high, and
Oh.
industry what they did now, they have train their workers only. They
To give.
themselves give them methylene blue, or they take orally also, and the methemoglobin level starts dropping down.
They
And
take methylene blue orally.
they ask them to drink. and uh, and I will tell you a story of one family. See, they were given gunny sacks of some chemical dye, and in one area they started washing that. The whole community got methemoglobinemia.
Ah.
But they were like mild cases, so didn't get reported. And as Dr. Rane has said, I had recently 2 months back one child was referred by school that they found that the child's fingers are little bluish, and so they and this child was investigated with all the investigation for cyanosis, but they couldn't find the cause of cyanosis, whether cardiac, respiratory, and they missed the bus because methemoglobin level was never done. When I did it, and it was about 43%.
Wow.
But child was quite robust, developing properly, no symptoms. Parents have never complained, child has never complained whether breathlessness or any other organ malfunction. Then patient was referred to Dr. Amit Jain, and all studies done like this baby, and again they were having mutation of the gene. And he has put the child on again oral vitamin C. That's all. But I think methylene blue for acquired varieties of methemoglobinemia, you can give them without any risk. So we can keep they are available in ampoules actually, 10 ml, 20 ml. So sometimes 500 ml bottles are also available. I don't know whether they are now available, but MIDC Tarapur area, they used to keep. But now with the safety measures and
मी जे मागवले ते 10 ml चे व्हायल होते सर. म्हणजे
10,
जस्ट
20
मागवून
ml
ठेवलेले, जस्ट लागले तर वापरूया. हो.
And they are not very costly.
नाही,
We are just worried
500
because what will happen if we give IV, so we tend to become little
Cautious.
But I think it is quite common methemoglobinemia. But this
And-
child, 10-year-old, there is nothing wrong. But Amit said that in the future, because of this high level of methemoglobin, there is a chances that his organ damage may take. So we'll have to take care of that. A persistent low hemoglobin level is not good, and high methemoglobin level may lead to some major organ damage like heart, lungs, or a kidney, and especially liver.
So the level of methemoglobin in the blood will not change with vitamin C, right?
No, it will not change, I think.
No. So it
Then
will
how
not-
will cyanosis go? Then how will vitamin C help?
Yeah, ते बोलतात the vitamin C, no, it helps in converting ferric to the ferrous form of hemoglobin.
Okay.
So vitamin C
Available
helps
to the organs.
Tissue.
Organs. So the ferrous form will, I mean, it can bind the oxygen.
Okay.
So it will help in improving the oxygenation and everything. The vitamin C.
Okay. Very nice, Praful.
Sir.
Very nice topic for discussion and lots of sharing. Thank you.
Sir, my
And we
question to
learned a lot again. Thank you so much.
There
Thank
is
you, Praful.
there is one more question.
Sir, my
Yeah.
question to Rane sir regarding the precipitating factor for the congenital methemoglobin. Are there any precipitating factors?
Yes, I mean, there are said like any infections, sepsis, and other things can precipitate the methemoglobinemia, congenital methemoglobinemia.
Thank you.
No, I mean, no particular thing. In general, they said that any viral illness, any infection can precipitate the methemoglobinemia in those cases which are having the congenital methemoglobinemia.
So do we need to do the repeated methemoglobin level in this as
I,
well?
I don't think unless they are symptomatic, we don't need to do it. If the the same holds for the vitamin C also. In the critical phase and that phase, we start with the vitamin C, continue it for few weeks, and then explain um, the presentation of the
signals.
disease and how it can manifest.
Yeah. We have come across one child who was methemoglobinemia with the G6PD, a deficiency. So, so there is any role of actually it is contraindicated in
Yes, yes,
G6PD.
yes. So
So
the way the methylene blue works is it takes H, the hydrogen ions and electrons from the NADPH. Okay, and NADPH is produced in the body by the hexose monophosphate shunt, which is governed by the G6PD, glucose 6 phosphate dehydrogenase. If G6PD is deficient, that methylene blue has no room left to
Role to
work.
play.
And on the contrary, it can bring about the severe hemolysis in the patient who are having this. So vitamin C, it is said the high doses of intravenous vitamin C is given in the cases where there is life-threatening methemoglobinemia and there is contraindication to using methylene blue. I don't know how often we'll come across such cases and all these things, पण ते आता just वाचलं त्याच्या संदर्भात मी just grossly knowing certain things.
thank you, sir.
Super.
Thank you, sir. It was a very interesting case and also a very good discussion after that. We really had a lot to learn from this. So let's move on to our next speaker. As we all know, our beloved Dr. Anjali Gokarna, who is a senior pediatrician practicing in Vasai. She is here to give a talk on constipation today. Ma'am, we can begin with your session.
Pallavi, can you share my slides, please?
Yes, ma'am. Sharing. Yes,
Yeah.
ma'am.
So I had given this talk at Mahapedicon, and it was the first talk in the morning at 8 a.m. And I was really worried that I had stalled. The topic I was given was the stalled gut. So I was really worried at that time that maybe I had stalled many people's gut at that time. But there was quite a few people in the audience, and I was happy at 8. There were people willing to listen to such a topic. Hemant sir has raised his hand. Yes, Hemant.
Yeah, only non-constipated came.
Absolutely. And they all had sattu. Or at least I hope. And sattu, someone said not to be given less than 2 years, but I'm so,
It is a winning food. It is the right winning food.
Exactly. So I'm so impressed by this that I'm going to start sattu. And in fact, we do give it in some way or the other because आपण गहू तर देतो, चणा पण देतो आणि भाकरी तर खातातच मुलं. So yes, I
So
don't see.
coated fish will taste great.
Yes. So actually, we have covered constipation quite a few times, and but I want to share it because there's something that while I was preparing the talk, I learned a lot, and if there is just one point I want to impress is that it will be given that important point will be given at the end of the talk. So that is what I just wanted to say, and. I am of the belief that when you listen to a topic, you learn, a lot. But when you present a topic, you learn the most because you have to read at least 10 or 20 times more than what you're going to say that little bit. And I
That
see
is
Yugal.
so true. So true.
Yes. because we may read a lot, and to condense all that into 10-15 minutes is something that is very, very yeah, important, and we learn a lot. Yeah. So going to constipation, and we all know this joke about, yeah, next slide, Pallavi. About this big chief who says no shit, and then finally the doctor goes on increasing the dose of the you know uh, drug, and then finally there was just big shit and no chief at all. So that was one of the jokes. And next slide, please. And there's a whole movie called Piku, which was made on Amitabh Bachchan's constipation. So constipation is a very, very common occurrence with us. Next slide, please. So, and if you, in your general practice, care to ask patients, then you will find that they have said here 3%, but I'm sure there are a lot more patients who don't come to the pediatrician and who silently suffer because of constipation. And they say that 3% of our patients and 30% of visits to gastroenterologists are because of constipation. And constipation basically is either functional, where it's just because of diet and improper diet, and otherwise it's organic because some underlying either gastrointestinal or hormonal problem. And 95% of patients are functional constipation. Yeah, next slide, please. But what are the effects of constipation? We may think, oh, what's the big deal about being constipated? But there is local pain, fissure, bleeding. There's poor appetite. So most of our children say they have parents say that their children have poor appetite. This reminds me of a joke. One of my friends, he said that I have two OPDs and I keep a junior in the other OPD. And I tell all of them, जिनके बच्चे खाते नहीं है वो OPD में जाओ, because not eating and poor appetite is such a common and an irritating problem. Of course, it's part of our practice. So poor appetite, abdominal pain, nausea could be a problem of constipation. And the family is totally preoccupied and distressed because of this uh, complaint. There is stool incontinence, there is fecal soiling, there could be urinary problems, and even urinary tract infection. In fact, if you see the prescriptions of any nephrologist, pediatric nephrologist, of course, you will see that most of them do contain a laxative. Then chronic constipation causes loss of rectal tone and perineal muscle weakness. And in long-standing constipation, there could be hernia or even prolapse of piles. And that is why prolapse of piles, especially in pregnant women, they do give them a lot of laxatives. Functional constipation, what are the criteria? So there are criteria which are put by Aspergan or by the NICE guidelines, and they say that if any of these two are there, then you can call it functional constipation. That is, if the stool frequency is 2 or less per week, history of hard and painful bowel movements, large diameter stool, if there's fecal incontinence, and this is often thought of as diarrhea, but actually it is fecal incontinence, that is watery stool escaping from a block of hard stool. And if you examine per abdominally or you do a per rectal examination, you will see that there are fecal masses. Next slide, please. So how do you know what is the type of stool? And now I have started doing this. I have a Bristol stool chart in my OPD. And when I was in Maha IP, I gave this Bristol stool chart to everyone. And you can download this from from Google or from the net. And please, next slide. And this slide shows what are the types of stools, and there are 7 types of stools. And the first 3 are very hard stools. The fourth stool, which is supposed to be the ideal stool or the stool that is desired because it doesn't cause any pain and it is a normal stool. And they said that it should be soft like a softy ice cream or like toothpaste. So next time you use toothpaste, remember what should look like that. And that is called the type 4 stool. And type 5, 6, and 7 are varying grades of watery stools or liquid stools. Next slide, please. So every child, yeah, next slide. Every child who has constipation should have a Bristol stool chart with them. And if we have downloaded any, we should add it to the file and tell the mother and tell the child when he is old enough. Because children who are above 6 and 7 years don't allow their parents inside the toilet, and we will have no way of knowing except if they see the chart. So give a Bristol stool chart to every patient who has complained even once of constipation, and tell them what is the type of stool, and tell them to mark when they have noticed that the stool was not type 4. What are the features of functional constipation? Next slide, please. Generally, the onset is in the later half of the first year when there is faulty weaning. The children are always playful and active. They will not have any problem. They have poor appetite. They could have nausea. They may have retentive behavior. And I think Dr. Raksha Tate had taken an excellent talk on what is retentive behavior. And that is, I will show some slides which will show you what is retentive behavior. It looks like as if the child is straining to pass stool, whereas he's not really. He's trying to hold back the stool because it's painful to pass. The child grows well in height and weight, so such a child will have poor appetite. But if you see his height and weight, he will be doing very well, in fact excellent, because they eat a lot of biscuits and junk and don't eat enough fiber. And there will be no abnormal findings, which I will tell you later. What are the abnormal findings we will look for? Next slide, please. So this is retentive behavior. They hold on because they don't want to pass a stool. They press their legs, they press their perineum, and this is because the painful bowel movement doesn't allow them to pass. So they are trying to hold back, and very often parents will say, "बेचारा बहुत वो जोर लगाता है करने को," but it's not really wanting to pass stools, but it's trying to hold back the stools. Next slide, please. The child usually stands to defecate instead of sitting. They're straining, crying, or squeezing the buttocks when feeling the urge, and will start running around or even hide behind curtains or furniture. Next slide, please. So it all begins with improper complementary foods. Next slide. They all start weaning with, if you ask them kya de rahe ho, biscuit, and if you say biscuit, then they'll say हाँ हम मारी दे रहे हैं ना. So mari they think is something which is, God given, and it's like the panacea for all kinds of foods. They give watery foods. They give just milk, as there are children who are on 1.5 liters of milk at 1 year of age, and the complaint is that the child doesn't eat anything and is crying because there is abdominal pain. Next slide, please. And also in older children, so generally it's a problem of young children, but in older children, they suffer from constipation because they don't get to go to toilet in school. They withhold their stools because they must have had even just one painful stool. So if just one painful stool is enough for the child to start having fear of passing motion and will start having retentive behavior. They may be too busy because they're playing and not want to go to stool to pass a stool, or they may be uncomfortable with public and school toilets, which used to be such a problem earlier. But I think things are changing and it is getting better, though I don't know about government or municipal school toilets. And the cycle worsens because with one stool they don't pass, and it gets harder and more painful, and it gets harder and more difficult to pass stools. Next slide, please. And this is the picture of that. So the stool is hard and there is retention, and then with more and more retention. And if you see in the last picture, there are, these blobs or these pellets of stool which are holding the, anus shut. But from the side, there is leakage of watery stool, that greenish stool that's passing. So this is generally fecal soiling, and parents think that the child has diarrhea. Next slide. So ask for when the child passed meconium, because if the child has passed meconium in the first 24 hours, then this is not organic. It has to be functional. Ask for the onset of constipation. If the constipation has been less than start of constipation has been At the age of less than 6 months, then it's organic. And what are the precipitating factors? So if change in diet or weaning diet, so these are the things. Or if there was fever, or if there was a day or two of poor appetite and constipation. So ask for these three things. Next slide. And when you're examining, see the height and weight. And like I said before, that if the height and weight is normal, then this child is definitely functional constipation. Look at the abdomen, if there's gross distension. Look at the spine, see if there are any dimple, hairy nevi, if there is any deformity in the lower sacral spine. Look at the anus and look at the anal wink. That means see that the tone of the anus is normal. Look for any neurological findings. So any child with constipation, please look at the ankle jerks. Next slide, please. Red flags, if there is, been a delayed passage of stools, like I said, for more than, if it was more than 24 hours, onset in the first 6 months of life, if there are delayed milestones, if there's abdominal distension, if there's an abnormal gait or absent deep tendon reflexes, this indicates lumbar spine problem. And abnormal position of the anus, absent anal wink. This reminds me of a child who was 1.5 years old and came for constipation. And we said, "Ke," but the father said the child passes stool every day. And it's a soft stool, and yet there is abdominal distension and there is pain. And then we went and saw, and this child had a rectovaginal fistula, and that child was passing stool. Luckily the stool was soft, and so was passing stool through that narrow passage in the vagina, which was soft. So that is why this child had abdominal pain, and still the child had abdominal complaints. So be careful. And if there is, every child doesn't need examination, but if you find that the abdomen is distended, do have a look at the perineum. So if you find that there is an abnormal position of the anus or even an absent anal wink, then that indicates a problem. Look at the lumbar spine if there is a tuft of hair or a sacral dimple, and look if there is refractory constipation, because if you have given many medications and they're regular with it, and yet you find that it is refractory, please look for an organic cause. Next slide, please. Generally, the history will tell you all and no tests are needed. Only if you suspect a secondary cause will you do a test to see what that could be. Next slide, please. How do you manage? Now, this is the most important learning point I wanted to share. Yeah, please, next slide. What is management? There are multiple things you have to do. You have to counsel the parents and tell them that passing a regular normal, the consistency of the stool, the frequency of the stool, that the child should feel that he has evacuated completely, that water and fiber are important, and that behavioral therapy is needed and toilet training is needed. So what is behavioral therapy and toilet training? Is that the child should get a reward for just going and sitting on the toilet potty, not necessarily only if he passes a stool, but at least for making an effort. And the lifestyle should change from this child passing when he feels like, rather make this child sit on the potty every time after a meal. And of course, there are physical activities which the child should get involved in. And then, most important is medical therapy, because the child will have tried everything before that and has come to you now for medical therapy. But we have to stress on all the 5 components of constipation management. Next slide, please. So, like Dr. Hemant Joshi always says, that 50% of our diet should be fruits and vegetables. And look at the colorful palette that God has given us. And we should encourage children to eat at least 5 colored things every day. So, this is very, very important to stress. Next slide, please. And yeah, and to drink adequate water, because stool retention leads to lots of dryness of stool, and drinking adequate water is very important. Next slide, please. And of course, our Indian posture is very, very good for passing because the whole rectum and the passage becomes in a straight line. And this should be encouraged because most often children are made to sit on an adult Western toilet. Now, unfortunately, all our toilets are being made Western type, and it's difficult for children to squat on that. And also it's too large a ring, so getting the adequate size of ring etc is important. And next slide. And getting a stool to raise the level of the legs so that the child gets enough pressure to pass. And also for very young children, having a potty seat to sit on to pass stool is good and important. Next slide please. And engaging in lots of physical activity, and this has become less unfortunately because of the mobile culture. Next slide. And there are a whole lot of medications that can be given, and I used to get very confused earlier as to what is the right kind of medication to give this child. Next slide please. But now the standard or the best line of treatment, standard line of treatment has become macrogols or PEG therapy, that is polyethylene glycol. These are all synthetic glycols that are given to the child. They are not absorbed by the body and they have great water absorbing capacity. And what they do is that when they get mixed with the stool, it absorbs a lot of water in the gut, and that increases the bulk of the stool, and that is what helps it as a laxative. Next slide please. So there are a lot of macrogols which are now available. It forms the mainstay of treatment, and it's a very safe agent for all children above 6 months of age. And the dose is 0.2 to 0.8 mg per kg per day, and it works out to half to 1 sachet a day. So there are sachets which are available. And the idea should be, the aim of our treatment should be that the child should have a type 4 stool. So if you get a standard child of say 2 years, then you have to give them 1 sachet and you have to ask them to dilute it well. So 1 sachet to be added in 60 ml of water, stirred well, and after the whole macrogols have dissolved, the child has to consume the whole thing. You start with 1 sachet a day, and if you feel that the child is passing a good type 4 stool, then you continue the same dose. And if not, and if the stool is type 1 to 3, then you increase by 1 sachet. And if you feel that it is anywhere 5 to 7, you can decrease to half a sachet or 1 sachet every 2 days. And it's important because most children who come to us are constipated for a prolonged period of time. So they may have constipation for 6 months to 1 year, and we have to counsel them to take this treatment for 2 to 3 months. And after 2 to 3 months, you have to taper it slowly over 2 to 3 months. Next slide, please. And how do you prepare the solution? You add the sachet to 60 ml of water. You can add more water, but never less. And after 5 minutes or so, after stirring, it gets completely dissolved. You can consume it. And preferably, you have to take it within 1 hour. And sometimes, so I thought that, there are many flavored macrogols available. And we have to get used to just one or two. Just like all medications, there are so many brands available. Just get used to one or two. I like giving Eslax and I like giving Movicol. Now these both are orange flavor, and I thought orange was a very favorite of the children until someone said that he doesn't take it at all. And then I tasted it myself, and it has a salty taste because sometimes they give it with electrolytes. So sometimes it tastes salty and some children don't like it. So it's a good idea. And I thought that for today's lecture, I would prepare a list of, and I think I'll do it over a period of time and share it on the group. There are many available. Some of them are available as strawberry flavor, some are flavorless, some have a lemon flavor. So there are many flavors available. Some have lime. There are some which have no taste at all also. So Movicol has a pediatric one which has no taste. It has an adult one which has no taste. So there are many choices. but you can study 1 or 2 and use it as you like it. You can add any flavor to this macrogol solution. You prepare it first. So you prepare it in water. You can add lemon to it. You can add the child's favorite juice to it. You can add fruity, whatever you like to it to see that the child consumes it. And if you, some of them are available as sachets with a powder. Some of them are available as a liquid preparation. So if it's available as a liquid, generally they say you give 12.5 ml with 50 ml of water. So it becomes 62.5 ml. Adult dose is 25 ml and to be added to 100 ml of water. So that makes it 125 ml. So every bottle comes with its own cap with measures of 12.5, 25, 62.5 and 125 ml. So they are conveniently dosed. And if you find that the child is, with 12.5 ml is not getting relief, you can make it 12.5 ml 2 times. Or if the child is very severely impacted. Next slide, please. So if the child has, then there are other medications also like lactulose. Now, I like giving lactulose to children who are less than 1 year. And the principle is the same. It's a sugar preparation which is not absorbed. It absorbs water into the gut, makes the stool bulky and makes the child pass a stool because of the bulk of the physical pressure on the rectum. So lactulose is also, and that also. Is there a question? So lactulose also, there is a dose and I prefer lactulose for some patients. Next slide. Yeah. Babies 1 month to, so less than 1 month, we don't give lactulose, lactilol, anything. But 1 month to 11 months, the dose is 2.5 ml taken twice a day. Children 1 to 4 years, 2.5 ml to 10 ml taken twice a day. And children 5 to 15 years, 5 to 17 years, you can give 5 to 20 ml taken twice a day. So you can adjust the dose as to how the child is passing stools. Next slide, please. So some children who are comfortable taking this, we can give, there is lactilol also available. And lactilol, they say, is preferable for children less than 6 months. So generally for children less than 6 months, that is, especially those who are on formula. This I never use for children who are breastfed and they think they are constipated, because breastfed children are not constipated. They pass infrequent but very soft stools. But if a child is on formula and you find that the mother says that he passes a large stool which is hard, then you could try this lactilol. And there are several companies that make this as well. Next slide. And then, of course, our age-old Cremefen, and there are good lacs and all. But I don't use this now because now the macrogol has become the mainstay of therapy, and I'm very comfortable using macrogols. Next slide. And then there is this drug called sodium picosulfate. And we can use this also. Its name was Piclin. You can use it as a rescue therapy. That means a child has been on regular therapy, was doing well, but occasionally has had a lot of, non-fiber diet and then has constipation. In spite of that, you can use either Piclin or some other Bisacodyl and Senna. I have no personal experience with these. So these you can do when the child is on maintenance therapy. Next slide. And disimpaction is done when a child has retention for a very long period of time, has abdominal distension. You can feel fecal masses and the child is very uncomfortable. And then, this is fecal impaction. And you can do home management with large doses of macrogol, or you can, in OPD, you can give enema, rectal enema, and disimpact the child. Next slide, please. And disimpaction only in specific cases, only if you can feel fecal masses, and the mother has complained that child is straining very hard and has severe pain. And if you feel a mass on per hour PR or PA examination, and I have said all this. And the home therapy, with macrogols is given over 6 to 7 days, because it takes very long for the disimpaction to take place, and the parents will complain that it smells awful, which it does because the stool has been in the gut for so long. And also, the endpoint for a disimpaction should be 2 watery motions, and then you can reduce the dose or stop for a day and then restart with maintenance dose. So if you had given daily, and the doses for disimpaction are very high, you can even go up to 4 sachets 2 times or 2 sachets 4 times a day. So the doses are very high. Next slide, please. Now I want to present some cases. Next slide. A mother brought her firstborn who was 6 weeks old for constipation. He had not passed stool since the last 5 days. This has happened in the past too. The child is feeding well, no vomiting, there's no abdominal distension, there's no sign of hypothyroidism, and TSH at birth was normal. The stools in the past have been soft. Now, what is this? This is normal breastfed stools. So that's it. Next slide, please. Case 2, a 5-month-old child breastfed till now, normal stooling, no delayed passage of meconium. Mother had to join work, so added formula by bottle and Nachni Sattva. 2 episodes of severe stool retention. There was straining, hard stools, dry and almost like an adult stool in large diameter. This is a real case. And what was done? So this was obviously because of the change in diet and counseling, change in diet, and lactulose. I added lactulose for this child and the child was better. But then obviously we have to tell them about starting other diet, and we can introduce fiber rich diet. Next slide, please. A 10-month-old child mother was feeding diluted milk and rice kanji. This child was constipated. There was abdominal discomfort, poor appetite, and failure to thrive, poor weight gain in last 3 months. Now here again, we know that this is because of diluted milk and rice kanji, no fiber at all, and very dilute feeds. And like Dr. Heman Joshi said, 90% is water, so she was giving only water. Next slide. So obviously this was diet induced. A 2.5-year-old child drinks only milk 1.5 liter, had abdominal pain, withholding behavior, used to go in the corner of the room and straighten his legs and strain. This is a real case. And parents think that this child is training to pass stools. And this child is only in nappy all day because both parents are working. So here again a faulty diet and only milk which has no fiber, 90% of water. Next slide, please. A 4-year-old child, previous history of constipation, taking treatment on maintenance lactulose. Both parents are working. Again, child in nappy all day at daycare and no response after 2 weeks. So here we have to again check whether this child has taken lactulose properly, increase the dose if needed, tell them about adding fiber. And 4 years is a good enough age to start toilet training, and the toilet training should never be very early and should not. So when do we start toilet training? Toilet training should start when the child can indicate he wants to pass a stool. So earlier a child only after has passed stool tells that he has passed a stool, but so this happens generally between 1.5 to 2 years of age, and it's good not to try to train a child before that. Next slide, please. So here we had to
Sorry
just...
to interrupt, ma'am, but we are running short of time, so we will have to wind up a bit faster.
I will. Thank you for reminding me. This is a 10-year-old girl with pyelonephritis, constipation history since many years. There was family dysfunction and this child had retentive behavior. Next slide, please. 8-year-old boy with fecal incontinence. So this child had severe constipation for a very, very long time. And this child was too embarrassed to go to school. Next slide, please. Had needed psychotherapy as well. Now we'll see some cases of secondary constipation. I'll go very fast, Yugali. Next slide. This is a child obviously with hypothyroidism and constipation. Next slide. This child, you can see the large bowel and retention. Next slide. This girl, look at this. This child had cystic fibrosis. This child died at the age of 3 years because of staphylococcal pneumonia and cystic fibrosis. She was also severely constipated. So this is secondary cause. Next slide. This child, can you see the terminal rectum? It's a string sign, and that's because of Hirschsprung's disease. Next slide. Same child, no, not same child, this is a different, that was a small segment Hirschsprung's. Look at this large segment Hirschsprung, and look at the proximal bowel dilatation. Next slide. Again, a large, that same child in lateral. Next slide. And this is the picture of that child. So can you appreciate, if you see abdominal distension, then please think of secondary constipation. Next slide. This is fecal retention. You can see the gas shadows. Next slide. This you can see anal dimple, a hairy tuft. Next slide. So if you suspect secondary cross, do not treat, refer to appropriate specialist. Next slide. Pallavi, next slide, please. So prevention is better than cure. Supplementary, high fiber, age appropriate toilet habits, exercise and food. Next slide. That's it. That's all. Thank you. And I'm sorry to have exceeded the time.
Thank you so much, ma'am, for this wonderful session. You have extensively covered the topic and a lot of new concepts too. And the image-based discussion was really good. Thank you so much.
Thank you.
Do we have any questions? If we have any
Dr.
questions, we
Hemal
can
Joshi
take the
sir wants to
questions.
talk. Yeah.
So you are not
Sir, you are
audible.
muted.
Unmute.
लोकांसाठी एक व्हिडिओ कर, जसे आंबेडकरांसाठी करते तसे, बिफोर टुमॉरो नाईट 24 hours टाइम. आधी कोकणीमध्ये कर, मग मराठीमध्ये कर, मग इंग्लिशमध्ये कर, मग हिंदीमध्ये कर. सिरियसली हा.
या. थँक यू.
रोज एक व्हिडिओ कर, तर महाराष्ट्र छान होऊन जाईल. ऍटलीस्ट वसई कॉन्स्टिपेशन फ्री होऊन जाईल.
Thank you. Thank you, Hemant.
Now we have got Dr. Yugali to tell us about the vitamin deficiency and relation of vitamin D in sickle cell disease. So she has done extensive research and presented this paper in NeuroMBCon Plus. So Dr. Yugali, please share your slides.
I want to say something about Yugali. Yugali has worked in ICMR Dahanu for a year, and she showed exemplary dedication, and she was always present at the sickle cell anemia OPDs that IAP Palghar has been conducting. And even after she completed ICMR job that she was doing, and now she is at Vedant Hospital, there are, every time she is free, so that's almost every time she does attend our OPDs, and she handles it very well. Thank you so much, Yugali.
Thank you so much, ma'am, for this introduction. So I shall begin with my topic today, that is vitamin D, hidden deficit in sickle cell disease children. This paper was published, and I had also presented in it in the Navi Ambicon conference. So as we all know that, can you see the changing slides? Yes.
Yes, Yugali.
Sickle cell disease is a genetic disorder with painful crisis, anemia, and organ complications. So children with sickle cell anemia have high nutritional needs due to increased metabolic demands, chronic inflammation, and potential malabsorption. And thus, there is an increased risk of deficiencies. So as we know that vitamin D deficiency is common worldwide and more frequent in sickle cell anemia patients. Vitamin D is important for the bone growth, immune functions, and the inflammation control. Low vitamin D levels leads to bone problems, infections, and poor quality of life in sickle cell anemia. High protein turnover due to the erythropoietic demand leads to the kidney damage, and this in turn worsens the vitamin D deficiency. Rural children face added risks from the poor diet and limited access to the healthcare and nutritional supplements. The aim of the study was to assess the vitamin D levels in the sickle cell disease children in rural settings and to determine the prevalence of deficiency and insufficiency, and also to evaluate with the demographic factors and clinical outcomes. So this was a cross-sectional study which was conducted among 106 children from the age group of 6 months to 18 years with confirmed sickle cell disease reports, which included both sickle homozygous as well as heterozygous, that is sickle beta thalassemia pattern, who were attending sickle cell clinic or admitted to the pediatric ward in our tertiary care center. The quantitative estimation of vitamin D levels, that is 25 hydroxy vitamin D, was done by the MAGLUMI fully automated chemiluminescence immunoassay analyzer. And the inclusion criteria included the patients diagnosed of sickle cell disease of SS homozygous as well as S beta thalassemia pattern on HPLC between the age group of 6 months to 18 years. The exclusion criteria, the children more than 6 months and older than 18 years were not included, or children with other types of anemia like iron deficiency anemia, thalassemia, pernicious anemia, children having any other congenital anomalies, or patients who were already on the vitamin D supplements and known cases of chronic kidney disease, chronic liver disease, or anemia of other etiology were excluded from the study. On analysis, we found that as the figure represents, there were 106 children, among which 51 were females and 55 were males. The total sample size was of 106. The distribution indicates a balance of both the genders, with a slightly higher proportion of the males than the females. And also, the levels which we took, the figure, the table aside represents the deficiency and the insufficiency. The values which we took into consideration were the deficiency was less than 20, insufficiency values between 20 to 30, and more than 30, that is normal or sufficient values. So the distribution of vitamin D levels across the different age groups, among them 60 had shown vitamin D deficiency and 46 had shown vitamin D insufficiency. Highest deficiency was observed in the 13 to 18 years group, which were about 28 cases, and which was followed by 7 to 12 years, which was 23 cases. Insufficiency was more prevalent in the 3 to 6 years age group and 6 months to 1 year group, in which the case 19.6% cases and 10.9% cases. Over here, as we can see, the chi-square and the p-square value were significant, and thus it indicates that the vitamin D status varies significantly across the age groups, but there is no as such gender bias. The results which we got, we can see through this representation as we have divided in the 5 age groups. We can see that the adolescent group has more of deficiency, and the age of 1 to 3 years has more of insufficiency. So the study of this 106 children found that 60 children had deficiency and vitamin with a mean value of 16.5 plus or minus 3, which was highest in 13 to 18 years of age group, which included 46 children. And the insufficiency peaked at 3 to 6 years with a mean value of 24.7 plus or minus 4. The p-value was significant, 0.0162. So as we can see that the findings indicate that vitamin D deficiency is most prevalent among the adolescents, that is 13 to 18 years, and children 7 to 12 years. That is nearly 85% of all the deficiency cases. And in contrast, vitamin D insufficiency was more common among younger children, that is 3 to 6 years and 6 months to 1 year. Children with sickle cell anemia face high nutritional demands and frequent deficiencies. So deficiency increases the risk of the bone diseases, the infections, poor quality of life, and the crisis episodes that they face. So sickle cell anemia related protein turnover and kidney damage further worsens against the deficiency. This mechanism underlying the association between the vitamin D deficiency and sickle cell disease are complex and multifactorial. However, it is clear that vitamin D plays a critical role in maintaining the immune function and preventing the infections. And also the rural children are at a higher risk of developing this due to the poor diet and the poor facilities that they have. So in conclusion, this study signifies that vitamin D deficiency was more prevalent among adolescents and children suffering from sickle cell disease, highlight the importance of considering age as a factor for the vitamin D levels in sickle cell disease children.
The results are consistent with many previous studies and emphasizes the need for targeted interventions to promote the vitamin D supplementation and healthy lifestyle habits in these populations. So the further healthcare providers should prioritize the vitamin D screening and supplementation, and particularly among the adolescents and children, which is the growing age group. So further studies focusing other nutritional deficiencies which will affect the health and well-being of the sickle cell disease children should be carried out to include the necessary supplements and thus enhance the quality of life and thus prevent the further complications. Thank you. So these were the findings of my paper. If anyone has any questions, we can discuss.
What was the reason for the adolescent to have more vitamin D deficiency than
Can you
the
close the
toddler?
slides?
I can say that actually there is also a bias that in our population, more of the adolescent group was included. As sickle cell disease mostly, or the OPD attending patients are mostly of the adolescents. They present with crisis after 6 to 8 years of age. So more of the population that we got was above 8 years of age or about 12 years of age. And so we have a maximum population size of that age group, which could have led to a bias of more presenting in deficiency. But also otherwise, as the during the adolescent period, the metabolic demands are more. So even that could be a reason.
So were these patients on hydroxyurea, or is there any drug interaction occurring?
We have to study that further, I suppose. The patients were already on hydroxyurea. The sample size included all the 106 children were already diagnosed cases and they were started on hydroxyurea and folic acid.
नॉर्मल विटॅमिन डी किती मुलांचं होतं?
Normal, out of the 106 children, around 12 children were only having normal vitamin D. Rest all 85%, that is 85% were in deficiency or insufficiency. 15% we can say were normal.
आणि कंट्रोल स्टडी नाही नॉर्मल पॉप्युलेशन
No.
मध्ये काय इन्सिडन्स आहे?
That is a limitation, I will say. We should have studied.
पण तुमचा अभ्यास असेल ना जनरल बाकी
General also we find that almost 70% cases मध्ये विटॅमिन डी डेफिशियन्सी असतेच आणि त्यात सुद्धा अडॉल्संट एज ग्रुप मध्ये जास्त डेफिशियन्सी दिसून येते.
म्हणजे चार चौघांसारखेच आहेत.
हो.
म्हणजे काय खास म्हणजे सिक्युलर आहे म्हणून जास्त विटॅमिन डी कमी असं काही नाहीये. सगळ्यांना सगळं भारत उपाशी आहे हे पण उपाशी आहेत.
हो, विटॅमिन डी डेफिशियन्सी इज अ प्रॉब्लेम. We need to do further study on this with control and cases so that we can derive if the sickle are more prone for the deficiency.
तुमचा एमडी ला थिसिस होता का?
नाही, हा थिसिस नाही आहे. थिसिस म्हणजे we just performed this study.
प्राऊड ऑफ यू. रेअर गोष्ट आहे, कोणी करत नाही असं काही. गुड. नेक्स्ट नोबेल प्राइज इज पेंडिंग. गुड. You will do a great job.
These are just baby steps, sir. Thank you for your motivation.
You grow through this. There are even thesis is meant to teach you research methodology.
Yes, sir. So my thesis topic is also on hemoglobinopathies. I am studying assessment of puberty and serum gonadotropin levels in hemoglobinopathies, including both sickle cell as well as thalassemias or G6PDs.
Any control?
I have a quiz control study. Both. I am comparing both.
Good.
For thesis.
Excellent, Yugali. Excellent.
तो युग प्रवर्तक. छान.
जुग जुग जियो युगाली.
ही स्लाइड बंद करता येईल?
Yes.
लोक एकच थेसिस करू शकत नाही, तू 2 टॉपिक केले, क्या बात आहे. छान. We're lucky to have you in Palghar.
Thank you so much, sir, for all the motivation and support.
We will host you a lunch or dinner sometime.
Yes, sir. Sure, sir.
Hemant is from Virar.
All IPs invited. At a place of your choice, date and place of your choice. So just slide.
Usually you have to stop sharing the slides.
Yes, I'll just.
येत नाही, नवीन आहे ती.
नाही तिला जास्त येतं सर आपल्यापेक्षा. येस. हा. सो थँक्यू युगाली. खूप मनापासून धन्यवाद डॉक्टर हेमंत जोशी सर. Dr. Praful Rane, Dr. Anjali, and Dr. Yugali for moderating the session as well as presenting a research paper. And thank you, Pallavi Madam, for your collaboration and contribution for this CME.
And all
Thank you, Anuradha, for getting us MMC points.
And all the 10 survivors.
Yes, yes.
Okay.
Thank
Thank
you.
you so much, ma'am, to you as well for giving me this opportunity. Really grateful. Thank you so much.
We should begin with epidemiology every time. It should not go because we did not remember it or there was no time. So we should begin with epidemiology. That makes the difference to everybody.
But we can still talk about it.
Yeah, sure.